Right. Is everyone here? Guys, can you all hear me? Let's start the session now. I need to see some faces, huh? Yasser is here. Okay. So today is the clinical skills session, right? All right. Okay. So yesterday, right? Guys, you all can hear me? All good? All good? Yeah. Okay. So yesterday we talked about the basics. We talked about the pathophysiology of what's going on, right, in ischemic heart disease, and we talked specifically, right, about the stable plaque, the unstable plaque, what they mean, right? And we talked about some of the ECG changes that we are going to see, and we talked about our stable angina, right? And we talked about the diagnostics and management of stable angina as well, right? So today we are going to go to our more acute condition, right? Yesterday we talked of a bit more chronic condition, which are stable plaque. So today we are going to talk about the unstable plaque, right? And we are going to talk about our acute coronary syndrome, right? Acute coronary syndrome, right? Acute coronary syndrome. Now, look at this, guys. When we say acute coronary syndrome, what are the four entities we have? Yesterday we have mentioned what are the four entities of acute coronary syndrome? Yes, sir. Just recall.
Unstable angina.
Unstable angina. Excellent.
Non-ST elevated myocardial infarction and STEMI.
And STEMI, non-ST elevation myocardial infarction. And we have STEMI. And do you remember one more? One more? Something regarding some bundle branches? Anything?
New onset left bundle branch block.
Nice. New onset left bundle branch block, right? Left bundle branch block. And then there is sudden cardiac death, which we are not going to talk about that much, right? So these are the four entities that we're talking about. Here, guys, when we talk about unstable angina and non-ST elevation myocardial infarction, right? What did we talk about, guys? When we say non-ST elevation myocardial infarction, with regards to the thickness of the cardiac muscle that is affected, what did we talk about? What did we mention? Is it a full thickness or is it usually a subendocardial? Then there is a non-ST elevation myocardial. Subendocardial. This is usually, so both of these conditions, guys, usually these are subendocardial. Whereas when you have an ST elevation, or when there is a left bundle branch block, we consider the full thickness of the endocardium to be, full thickness of the myocardium to be affected, right? So usually, if this is more subendocardial, right? What do you all think about the coronary artery obstruction, guys? Do you all think this is a full obstruction? Like if I take this as the coronary artery cross section, right? Do you all think it's a full obstruction or just a partial obstruction for these two, unstable angina and non-ST elevation myocardial infarction? What do you think?
Partial.
Usually this is a partial obstruction. So here, guys, this is usually due to a partial obstruction of blood flow, whereas an ST elevation coming with the full thickness involvement, right? And a left bundle branch block also, today we'll talk more about that. These are usually full obstructions, complete obstructions, right? Complete obstructions of coronary vessels, right? Okay. Now, so up to this point, we've even mentioned this yesterday, right? Now, tell me this. Okay, so we have our patients coming in, right? How is this patient going to come to you? What is the chief complaint? Can be either of these. We'll just take acute coronary syndrome as a whole. How is the patient going to come to you?
Sudden onset of chest pain.
Sudden onset of chest pain. Excellent. Okay. Anything else? Now try to compare and contrast it to yesterday's stable angina, right?
Angina at rest.
Yes, there will be angina at rest. Specifically, guys, what I want you to tell is, this is, you're correct, acute onset chest pain, right? Chest pain, right? That is not relieved by rest, not relieved by rest or GTN. Yesterday, remember we talked about GTN? Not relieved by rest or GTN, right? Right? So this acute onset chest pain, guys, that is not relieved by rest or GTN, right? Usually, guys, if we give GTN to a patient, how long, if a patient is having chest pain, and if that is stable angina, and we give the patient glyceraldehyde trinitrate, how long do you think the patient will take for that pain to disappear? In a stable angina case. Any guesses? Guys, it's please turn some of your cameras on. It's very difficult to teach otherwise, right? You can't always expect the answer to answer, right? Yes, sir, it's okay. You can go ahead, right? No problem. Okay, if we have a patient with stable angina, right? And we give them GTN, usually how long will it take for the pain to resolve? Stable angina. What do you think? It's okay. You can come up with anything. Anyone? Shaheen?
Around 1 minute, 2 minutes.
Yes, close enough. Usually, guys, we say maximum 5 to 10 minutes. Maximum 5 to 10 minutes. But yeah, usually most of the patients by 1 to 2 minutes, that right? The pain goes away, right? Maximum 5 to 10 minutes. But what's the feature with acute coronary syndromes, guys? You give them GTN 20, 30 minutes, still no relief, right? No relief at all, right? And pain is not improved with rest, right? So this is the characteristic feature about the pain. Then apart from the pain, now you all know what sort of pain is angina, guys? What sort of pain is angina? How do we describe the pain? Where is the location? Manari. Yeah, retrosternal. Good. Right? Retrosternal chest pain. Manari. What type of chest pain? How does the patient describe it? Is it a burning pain? Crushing type of chest pain. Excellent. Crushing type of chest pain. Good. Right? So crushing type of chest pain. Central chest pain. Retrosternal chest pain. Right? We talked about this yesterday. Now, also there can be what? Pain radiating to the jaw and the arm. And now yesterday, guys, I got a message. Good question. What does it mean when we say pain is radiating? What does it mean when we say pain is radiating? Now, this patient is having a problem in the heart. But what is happening? Right? He is feeling also the pain in the medial arm and the forearm. He can feel it. Somewhere in the neck, he can feel it. And somewhere in the jaw also, he can feel it. Right? So what is happening, guys? The problem is in the heart. How is this pain spreading to these areas? What do you all think? Any clues? No? Any hypothesis? Come up with anything. It's okay. You all can make mistakes. No problem. Anyone? Guys, I want you all to be more interactive today. Today is a right clinical day. I wasn't actually planning on using the whiteboard even today, but I thought maybe a little bit, right? So tell me. Wake up. Who are these students with their cameras turned off? Right. Right. Okay. Good. So tell me, why or how do you think this cardiac pain is coming from the arm, the neck, and the jaw? Any clues? Come up with something. Come on. I'm waiting for some answer. No one? Right. Okay, guys. Have you heard of nerve roots coming from the spinal cord? Right? You all have heard of nerve roots coming from the spinal cord, right? What is happening is, guys, this sensory nerve fibers, right, that are coming. I'll draw the spinal cord somewhere here, right? The sensory nerve fibers here, if we look at the spinal cord cross section, right? I will draw a large cross section, right? The sensory nerve fibers, guys, they come, and there is something called, there's a first order neuron, and then there's a second order neuron, and that will go up. We'll do neuro, okay? Don't worry, right? That is not today's class, right? It will go up to the higher cortices, right? So what is going to happen is, guys, some of these sensory nerve fibers that are coming from the heart, as well as areas like the arm, right, the neck, the jaw of the same side, these have the same second order neuron. The second order neuron is here, going upwards, right? They have the same second order neuron. So your brain is unable to comprehend if the pain is coming from here or these areas. So you feel the pain in all of these areas. Okay. It doesn't mean when we say pain is radiating, we are not saying that the ischemic pain here is going to these areas. That is not exactly what's happening. What is happening is this pain fibers, the sensory afferent pain fibers, they have the same second order neuron, right? So that will transfer the signal to the brain, and the patient perceives it as pain radiating to those areas. Okay, right? Understood? All good? Right. Then the next concept. Now, acute coronary syndrome, guys. As we all know, this is a medical emergency. This is a medical emergency, right? So if we are treating or if we are trying to manage a patient with a medical emergency, what are we going to do first? Are we going to take a history from the patient first? Are we going to do diagnostic investigations first? Or are we going to start managing immediately? What are we going to do? Is your next question. Think and tell me. Think and tell me. Come on. Guys, unmute and talk. So what are we going to do first? Management. Okay, good. So management, yes, we want to aggressively manage. But guys, exactly this is the thing. What we are going to do is all three must go simultaneously, right? You are doing a little bit of management, you are doing a little bit of history taking, and you're doing some diagnostic investigations simultaneously, right? When you're managing not just acute coronary syndrome, any emergency condition, right? Any emergency condition, right? So we will see today also. So this is emergency medicine, right? So one of your opening statements, even in your Viva exams, guys, this is what you're going to say. Since this is a medical emergency, right? My history taking, my diagnostics, right? And my management will go simultaneously or will go hand in hand. Okay. So you have to mention this, right? Then, so today, now we can't discuss all simultaneously, so we'll first start off with the history taking, right? We'll start off with the history taking. So in our history taking, right? Now imagine you have a patient in front of you coming, right? Is coming. Now I'm your patient. Okay. Now I'm your patient. You guys ask me questions. I'm your patient. I'm coming and telling you all, okay, doctor, I'm having a chest pain since the last 2 hours, right? And I'm sweating, right? My chest pain it's very painful. Okay. Now, what are you going to start? What is your first question, right? What should be your first question? Come on, guys, we'll discuss today. Otherwise, this is going to be boring if I just tell you all, you ask this. Right? Just think, I'm coming with chest pain to you. I'm the patient. What are you going to ask me first?
The location, the nature of the pain.
Good. Excellent. The location, the nature of the pain. What we want to do is, guys, we want to analyze this patient's symptom, right? The primary chief complaint, we want to analyze that, right? So firstly, what are we going to do? Analyze the symptom, right? Analysis of the chief complaint, right? Or the presenting complaint, right? What are we going to talk about? The Socrates approach, right? Socrates. Have you all heard this? Right? So what is this? Site, right? Onset, character, radiation. I write it down. Site, onset, character, radiation, whatever. What else? Associated features, right? What is T? Time duration. E and S, exacerbating and relieving factors, and severity. Okay. So how do we ask about the site? Now, you want to ask me, now I'm coming and telling you, I'm having a chest pain. How do you want to specifically want to ask me about the site? What are you going to ask? Come on, guys. Let's be more interactive. Satsarani, Karyavasa. How do you want to ask me about the site of my pain? Satsarani, which year are you in? I think she's stuck. Not sure. Okay. Right, guys. Anyway, how do you want to ask me about the site?
Central, retrosternal.
Right. So now, okay, good. Central, retrosternal, yes. But more than telling the patient, right? More than giving the patient words so that the patient could come up with an answer, what we say, the easy way is, can you point with one finger and show me where it hurts, right? Point with one finger and show me where it hurts. Now, yesterday, what did we talk about? Visceral pain. When you ask the patient, can you point with one finger and show? Can they show it? Majority of the time. Visceral pains, guys, majority of the time, they won't show us, right? They will say this entire area is hurting, right? Entire area is hurting. So that is your first question. That is how you ask for the site. Can you show me with one finger where it hurts, right? Then about the onset. How do you ask? Now, onset, guys, what we want to figure out was, first is a sudden onset or was this progressively increasing chest pain, right? That's what we want to know. So how do we ask the patient that? The easiest way is, guys, you ask the patient, do you recall what you were doing when the pain came? Why? If this was a sudden onset severe pain, right? The patient will exactly be remembering what he was doing. He will say, I was driving and suddenly the pain came, right? Or I was doing this work and suddenly the pain came, right? So the easy question to ask there than asking, how did this come? Was it a step-by-step increase or did it suddenly appear? Without asking like that, you be a little bit more tactful. You say, you ask, what were you doing? Do you recall what you were doing when this pain started? Okay, that is how we ask about onset, right? Onset. Then character we have already, right? The patient will usually tell us, but you can ask, what type of pain do you feel, right? Is it a crushing type of pain, a burning type? Because now you all know, guys, if it is a burning type, you have to think more about some other differentials as well. We'll talk about the differentials later today, okay? Is it a tightening type of chest pain, right? You have to ask these questions, right? Radiation. Again, now we talked about the radiation. You ask the patient, do you feel the pain in your arm, right? In your neck, in your jaw, right? You can ask this question. Sometimes they might say the back, right? They might say the pain is coming to the abdominal area. Patient will tell you various things. Okay. Okay. Right. Then the next thing, any associated features. Associated features. What do we mean by associated features, guys? Specifically when we are talking about acute coronary syndromes. Apart from the pain, what can these patients present with? Any associated other symptoms? Anything?
Tachycardias.
Sorry, I didn't hear you.
Tachycardias, fevers.
Tachycardias, okay. No, so tachycardia is something that we will discover on the patient, right? Specifically when we are checking the pulse and all, we can find this out. More than that, something that the patient himself, these patients, guys, they will come with sweating, right? Diaphoresis, right? They will come with excessive sweating, right? Sometimes the patient might have lost consciousness, right? And someone else brings the patient along, right? So these kind of manifestations you have to look for, right? Apart from that, sometimes, guys, specifically this acute coronary syndromes, these patients appear very worried, right? There's this sort of like a sense of impending doom, right? So they appear worried. They have these anxiety sort of features, right? They appear anxious, right? So these things you have to look for, associated features. Then time duration, you have to ask, guys, how long has it been since the pain started, right? Because we will talk about for our managements, there are some managements specifically related to PCI where there are time intervals, right? Where we can do these managements. If not, we cannot attempt those. Right, so ask about the time duration, then any exacerbating or relieving factors. Here, what are we going to ask about? Exacerbation and relieving factors. What are we going to ask about?
Rest.
Yes.
Pain or rest.
Rest, and then the other one, GTN. Specifically, you can ask, have you taken a nitrate at home? Most of the time, guys, you will meet a lot of patients, a majority of patients who are coming with the second or third heart attack. So in their first one itself, we have told them how to manage, if they are getting any symptoms, we have told them to take a GTN, right? So you can ask, have you taken a GTN? Has the pain reduced? Have you rested and checked, right? You can ask that. Severity. How do you ask severity? Huh? How do you ask the patient very severe? Is it severe or not?
How much distance can you walk or climb before the pain starts?
Now that is more of a stable angina question, right? Because stable angina is provoked by exertion. Here, guys, this is a sudden onset chest pain. And when the patient comes to you also to the hospital, his chest is still paining. Okay. That is what acute coronary syndrome is, right? So in that kind of a situation, we cannot really ask him, how much can you walk? No. Right? What we can ask him is, guys, have you felt anything like this before? This painful before? Have you felt anything like this before? Right? That's the question. And then sometimes in some other countries, guys, they use these pain scales and all. Here, we don't really use them, okay? Because the patient is already anxious, he's worried, you show them a pain scale from 1 to 10, he'll throw that at your face, right? So we don't usually use the pain scale here. But what you can ask is, has this happened before? And have you felt this kind of a pain before, right? You must ask that, okay? Right? So this is the analysis of the symptom, right? Analysis of the chief complaint, right? Then guys, the next thing we are going to do is we are going to ask a few questions from the patient about the differential diagnosis, because we want to rule out other kinds of chest pain to exactly figure out if this is acute coronary syndrome or not, right? Okay, right. So one of the primary differentials, guys, that we want to ask about, right, is aortic dissection. How do we ask about aortic dissection pain, guys? What are the questions? What can we ask the patient? Any guesses?
Does the pain radiate to the back?
Pain radiated to the back. Good. Pain radiated to the back, mainly the interscapular region. So you must ask that. Apart from that, what sort of pain is this, guys? Aortic dissection. What do you think? What kind of pain? Is it a crushing type of pain like in acute coronary syndrome? Guys? Yeah. Guys, don't, you all have sent messages, okay? Okay, just unmute and talk, huh? Unmute and talk, right? Look at this, guys. Aortic dissection, this is mainly a tearing type of chest pain, right? Okay? So tearing type of chest pain radiate into the back, right? Then, what is another very important relationship, if I talk about a genetic disorder that is associated with aortic dissection? Have you all heard of anything? Have you all heard of something called Marfan syndrome, guys? Right? Marfan syndrome, right? So this Marfan syndrome has a high association with aortic dissection. So you can ask the patient, one thing you can ask, are you a diagnosed Marfan patient? Specifically, guys, you can see, visually, you can see Marfanoid features, right? These patients are very tall, very thin most of the time, right? Their arms, when they're standing, right? Their fingers will reach below their knee joint level, right? When they're just standing, fingers are reaching below the knee joint level, right? And they have this thumb sign and the wrist sign, right? We'll talk about more. I'll send some photos as well to the group, right? So these kind of features we are going to look for, and we can ask the patient as well. Then, what is another very important risk factor for aortic dissection? Very important, the most important risk factor. Guys, I want you all to be more interactive today. Come on. Huh? Hypertension, excellent. So you ask about hypertension, right? Hypertension. Manari, which year are you in? Fifth year. Which university?
Italian Medical Institute.
Good, excellent. Okay, so fifth year. Okay, so we are going to ask about hypertension as well, right? Then, apart from this, another differential. So these questions you ask about aortic dissection, right? To try and rule that out. Another one, guys. Acute pericarditis. Right? Acute pericarditis. Right? What sort of pain does pericarditis come with? Pricking type of chest pain. Right? And this is also, guys, usually a central chest pain, pricking type of chest pain. And now, what is this pericarditis, guys? If this is my heart, right? The pericardium, right? Pericardium is something like this, right? Here we have two layers. So there is a fibrous and a serous pericardium, and the serous pericardium is further broken down into the visceral and the parietal, right? No need to know that much today. Just I want you all to know this pericardium is inflamed. This is what pericarditis is, right? Pericarditis is. So when there is inflammation in the pericardium, guys, now you all know our heart is usually nicely positioned, right? Cushioned between our lungs, right? Cushioned between our lungs like this, right? These portions are actually not visible when you look from the front, right? Okay. So what do you think happens whenever we breathe in? Our lungs expand, right? Our lungs will expand, right? Our lungs become bigger. So what happens, guys? They will push on this pericardium. Whenever we breathe in, right? They will come and push on if I draw a side view, right? If this is the lung and this is the heart, right? The pericardium of the heart. During inspiration, the lung will come and, right, rest on the pericardium. So what do you think about the pain? Huh? What is happening to the pain during inspiration? pain will increase, right? The pericarditis pain increases during inspiration. Okay, right? All clear, right? All good, right? So this is what we call what? This is what we call a pleuritic type chest pain. Okay, pleuritic type chest. This is not a pleuritic chest pain, guys. Okay, pleuritic chest pain is a pain originating from the pleura itself. This pain is coming from the pericardium, but it is also increased during inspiration. So we call this a pleuritic type chest pain. Okay, pleuritic type chest pain, right? So you can ask those questions to rule out something like pericarditis. Next. Okay, guys, again, one more thing, just based on the same phenomenon, right? Now let's tell the patient is lying down like this, right? And his heart is somewhere here, pericardium is somewhere here. When he's lying down also, what happens, guys? The lungs will fall down on the heart, right? The lungs will fall down on the heart. So when he's lying supine also, this is a face, huh? Okay? When he's lying supine also, the pain will be increasing in pericarditis. Okay? This is another feature. So the pain, pericarditis pain increases on lying supine and increases on inspiration. Okay? Both of these points. Okay? Right. Then, another differential. So these we've discussed aortic dissection and pericarditis. Another one, guys. Another differential is pulmonary embolism. Pulmonary embolism. Now, you all know, guys, pulmonary embolism usually originates from a deep vein in the leg. We call this deep vein thrombosis, right? From DVT, right? DVT is thrombus from a vein will travel up all the way, come to the heart, right? And it will go to the lungs, right? Lungs, where it will cause obstruction, right? What are the features of pulmonary embolism, right? That we want to ask the patient for, so that we can rule it out. Any ideas? Now, what is happening? Blood flow to the lungs is going to be obstructed. So what do you think about the breathing of the patient? Will the patient have any problems with breathing?
Tachypnea?
Okay, tachypnea, that will be a little bit later for the compensatory phase. But before that, he will have shortness of breath, right? He will have shortness of breath. It will be difficult for him to breathe. Shortness of breath. So that is one thing you can ask, right? Are you finding it difficult? You can even see it, guys, clinically. If you can look at for the what we call labored breathing. The patient will be, right, trying to breathe so hard, right? He's putting such an effort to breathe in air, right? So you can see what we call intercostal or subcostal retractions, right? You all know. So this is the sternum and this is the rib cage, right? So what is happening when there is labored breathing, guys? These intercostal muscles, they will go inwards during inspiration. So you all can see, right? You all can see the ribs very prominently as everything else is sucked in. Okay. So that is what we call intercostal or subcostal retraction. Apart from that, use of accessory muscles, right? You can see them, they're putting their entire effort, right, to breathe in. So you can look for those features as well. Then also, guys, now look at this. When we have a pulmonary embolism, right? What if it originated from a DVT? What is one important question you can ask them regarding their lifestyle or recent work or recent travel? Is there anything we can ask them? Any
recent history of surgery?
Yes, good. Recent history of surgery. Why are we asking about surgery?
Because they will be bedridden for a lot of days after surgery.
Excellent. So after doing the surgery, post-operatively, they will have bed rest, right? So when they are bedridden for that long a period, there is a high risk of thrombus formation, especially if they have hypercholesterolemia, if they have other risk factors like hypertension, diabetes, they are at a very high risk group. So they can form thrombi that then, especially when they ambulate suddenly, these thrombuses can break off and go up to the lungs. Anything else? So recent surgery, excellent. Anything else? What do you all think?
Fine. For a long period of time.
Yes.
Flown recently for long hours.
Yes, especially you can ask about their travel, guys. This is very common, especially in older individuals after prolonged traveling times, right? Because they're seated, they are not moving after long flights, especially, right? So you can ask them about their recent travel history, right? Especially long periods of time. Okay. And if you're looking at the clinical picture, what will you see if there is a risk of deep vein thrombosis? Now, what is happening here is in a deep vein thrombosis, there can be in one of these large veins, there can be a large obstruction, right? There can be a large obstruction. What will you see in the clinically? Clinically, what can you see in this patient? You can even ask that in the history. You can ask guys about any unilateral leg swelling, right? Now you all know bilateral leg swelling, something like edema, pedal edema. These will happen bilaterally. So when there is heart failure, these usually happen both legs will swell. But if there is DVT, specifically that limb will be swollen, right? That limb can be swollen. Okay, so you can ask the patient as well as you can examine that as well. Okay, right? Then, so that is another differential that we removed, right? Then the next differential, guys, the burning type of chest pain, specifically gastroesophageal reflux disease, right? And even peptic ulcer diseases, right? These are usually burning types of chest pain, right? And peptic ulcer diseases we'll talk about later. We have duodenal ulcers, gastric ulcers. These ulcers, there are some ulcers that are the pain exacerbates when you eat food, right? Some ulcers that are relieved when you eat food, right? We'll talk about those later in another topic. But mainly these are, guys, burning type of chest pain, Okay. So they are usually associated with dyspeptic symptoms, right? The patient, you can ask, have you been diagnosed gastritis, right? You can ask the patient straight away, right? Are you on any medications? Some of these patients, they are on like omeprazole and proton pump inhibitors, right? These kind of medications they are on. So you can ask, right? Okay. Clear. Then one more differential, guys, right? Pneumothorax. Have you all heard of pneumothorax? What is pneumothorax, guys? What is pneumothorax? What do we mean by pneumothorax? Huh? What is pneumothorax, guys? Answer. I'm waiting for an answer. Huh? Right? What is pneumothorax? Huh?
Air building up in the pleural space.
Yes, air in the pleural space. Excellent. Air in the pleural space, right? So when there is air in the pleural space, right, is an abnormal collection of air in the pleural space. When there is air in the pleural space, guys, what sort of pain do you think it will mainly be? If we take the patient's chest wall, is like this, like this, right? This is the chest wall, the hands, and this is the neck, right? Usually, guys, this pneumothorax chest pain. Pneumothorax chest pain is, guys, usually the patient will describe it as a peripheral chest pain, right? On the outside, not the central chest pain, right? Okay, usually they describe it as a peripheral type of chest pain, right? Okay, something like that. Okay. And again, when we have a pneumothorax, during inspiration, what happens? Our lungs expand. So whenever our lungs expand, will it cause pain or not? It will cause pain. And what type of pain is that? That is a pleuritic pain, not a pleuritic type pain. It's the pleuritic pain, right? Because the pain is originating from the pleura. Okay. It's the pleuritic pain. Okay. Right. So pain exacerbated on inspiration. So there are two pains that are exacerbated on inspiration. One is pericarditis. That is a pleuritic type chest pain. This is pneumothorax, which is a pleuritic chest pain. Okay. Right. Then there are some other differentials, guys, not very important, but you can ask about pancreatitis, right? We have epigastric pain. Usually they can also be radiated into the back. So the patient will show the epigastric area, right? More than the chest, epigastric area, a little bit lower down, radiated to the back, right? These kind of measures, and it will be worst on bending forward. Not very important, but you can ask, right? Okay, so this is our differentials, right? This is how we are going to exclude our differentials, right? Okay, clear? Guys, today I want you all to be a little bit more active, huh? Today we have some heavy topics coming ahead, huh? I'll talk about ECG, right? Some important stuff. Right. So now what did we do up to now, guys? In the history taking, we analyzed the chief complaint, right? We excluded some differentials, right? Now we are little by little narrowing in on our ischemic or acute coronary syndrome diagnosis. The next thing we have to do is, guys, when you get a patient, right? You ask about the current management. This is the third thing, current management. Why do you ask about the current management, guys? Now you might have just come to the ward. Okay. You might have just come to the ward and met this patient, but this patient might have been there since morning And maybe some other doctors have come and already looked at him and prescribed some medication. So you don't want to again prescribe those things now. So you have to ask, what has been done up to now, right? What has been done up to now? So what are the questions you can ask, guys? You can ask, have you been given any medications up to now after coming to the hospital? Or even sometimes if this is an already diagnosed ischemic heart disease patient, they might have taken some medication at home, right? Trying to alleviate some symptoms. So you can ask, did you take anything at home? After coming to the hospital, were you given any medications, right? Was there any medications given for your pain? Because you will see that when we come to the management, we are going to put these patients on morphine, right? You can ask the patient, right? Have they given any medications for your pain? What else can you ask? Yesterday, what was one of the most important initial diagnostic tests that we are going to do when we get a patient with chest pain? First diagnostic test? ECG. You ask, have they done an ECG? Have you done an echocardiogram? Right? These questions you can ask, right? Then, guys, you can ask. Today, later in the class, we'll talk about thrombolytic therapy, right? Streptokinase, right? We could talk about anticoagulation. You can ask, have you been given any infusions, right? Any infusions to your, to your arms, right? You can ask these kind of questions, right? And what can you also ask? Have they done an angiogram on you, right? And usually this angiogram word, everyone is familiar with, right? You can ask, angiogram done, right? Another thing is, guys, if they have, now yesterday we talked about, right, something called PCI. Today we are going to go into depth about PCI, percutaneous coronary intervention. But you can ask, has a PCI been done? Now this PCI term, guys, most of the patients don't really know. So what you can ask is, have they put a wire through either your hand or somewhere near your leg? We are usually using the femoral artery. So you can ask, have they put a wire through your leg and checked, right? And done any management, right? That's about PCI. So these kind of questions you have to ask about the current management, right? Because you can't miss these, okay? Right. Then, here, guys, you have to also ask about some possible complications. Why are we asking complications of acute coronary syndrome, okay? Why do we have to ask about these complications, guys? Because if these complications are there in the patient, we have to simultaneously manage those as well. Right? So what are these complications that we're talking about? Now, just let's take a look, guys. Look at this. If I draw the heart, right? Right, something like this. Right? Let's say this patient is having somewhere here a full thickness myocardial infarction. Right? ST elevation, myocardial infarction, somewhere here, right? Now, what are some complications that can happen? First of all, guys, you all know so this is if I draw our valves, right? Here we have our bicuspid or mitral valves, right? Our mitral valves, guys, how are they opening and closing? With the help of something called papillary muscles, right? We have something called papillary muscles here, right? And these papillary muscles at the apex of the papillary muscles, we have these structures called chorda tendineae, right? Something like this, right? And whenever the papillary muscle contracts and relaxes, the valve will be opening and closing, right? This is how it works. Now, if this base of the papillary muscle has had this infarction like this, what can happen to the papillary muscle? Papillary muscle can rupture, right? Papillary muscle can rupture. If the papillary muscle ruptures, guys, from the base, what is happening? This valve function, what will happen? This valve will just start regurgitating. It will just start floating around all over the place, right? It won't be working properly. Okay. So what is common, especially with left ventricular infarctions, guys? What is a common complication? Mitral regurgitation, right? Okay. This is one of the common complications. The next thing, now you all know, guys, somewhere here, we draw. Here we have what you call the ventricular septum, the septum, right? The ventricular septum. Draw this a little bit deeper, right? Something like this. Ventricular septum. Now, if I tell you there was a full thickness infarction here, ventricular septum, right? Full thickness infarction here, damage, destruction, fully gone, right? What is one complication that can happen here, guys? Specifically, if this patient was a high-risk patient, right? There can be a pathway created here, a gap created here. So what will happen? Blood will start moving like this. If there is a defect after an infarction, if there is a defect created in the septum, right, and the blood is moving, what do we call it? In a ventricle. This is a ventricular septal defect. So that is another complication, right? Another complication, ventricular septal defect. Okay, VSD, right? VSD. Okay, clear? Then, apart from this, what else, guys? Any other complications that can happen to this patient, right? Specifically, if I tell you, this entire portion, very large portion of the left ventricle has undergone infarction. What do you think happens to the contractile power? What do you think happens to the contractile power of the left ventricle? What will happen? Huh? Any clues? Tarushika is here. Good. Right? Right? Any clues, guys? What will happen here if there is a large portion of the ventricle involved? What will happen?
Ventricular fibrillation can happen.
Fibrillation? Not so much. We'll talk about it. There is a possibility of arrhythmias coming, right? We'll talk about that arrhythmias later. But more than that, guys, now, what is the function of the left ventricle? Specifically to pump out blood to the entire body. So now if this entire portion has undergone ischemia infarction, yesterday what did we say happens when there is infarction? Cells start dying, cells start undergoing necrosis. What is the other one? Hypokinesia, right? Do you all remember? That ventricular muscle cannot move, right? So what is going to happen, guys? Another possible complication is if the left ventricle cannot move properly, if it cannot pump out blood, if it cannot do the systolic diastolic function, heart failure, right? That is another complication, heart failure, right? So if there is a heart failure, guys, right? Now, tell me this. You all know, do you guys, please turn your cameras on. I want to at least interact with you all a little bit. If I ask cardiac output, right? Cardiac output. What do we mean by cardiac output, guys? What do we mean by cardiac output? Just what the word means? Huh? Come on, tell me. Yes, sir?
The heart pumping out blood.
Yes,
blood
exactly. Yes, the amount of blood that the heart can pump. This is usually given per unit time, right? Usually we take it per minute, right? Excellent. Now, if I say this is cardiac output. Cardiac output, guys, if you all have heard, right? First years, second years may be not, but others, it is equal to heart rate times the stroke volume, right? Stroke volume, right? Cardiac output equals heart rate into stroke volume. Now, what is happening whenever there is heart failure, guys? Whenever there is heart failure, the heart is unable to pump out properly, right? Unable to pump out properly. So the cardiac output will start dropping. Right? To compensate for that, to compensate for the drop in the cardiac output, what will happen? Our sympathetic system will be activated and it will try to increase the heart rate, right? It will try to increase the stroke volume. Okay. Now, if our heart is increasing the heart rate and the stroke volume to compensate for this cardiac output, right? What do you think the heart needs to increase heart rate, to beat faster, to increase the contractility, to increase the stroke volume? What do you think our heart needs? More oxygen. Now, what is our entire acute coronary syndrome problem, guys? We don't have oxygen, right? This is ischemia. So what can heart failure do, guys? One thing, heart failure can be a complication of the myocardial infarction, and heart failure itself can further exacerbate myocardial infarction, right? This is the concept I want you all to understand. Is everyone clear with this, right? Heart failure is both a complication of myocardial infarctions, and it can also complicate or worsen things if the patient is having myocardial infarction. Okay, right? Everyone clear? Right? Give me a thumbs up. Right? All good? Right. Excellent. So, heart failure, guys. How is the patient going to come to us in heart failure? Shortness of breath, right? We'll talk heart failure is a big chapter. Right? Actually, one of my favorite chapters, right? I will teach that to you all hopefully someday, right? Very interesting chapter. So anyway, we are going to have shortness of breath. We are going to have what we call the JVP, jugular venous pressure is going to be elevated. We can see distended neck veins, right? We'll talk about all the tender pulsatile liver. We'll talk about all of that. But for now, just know heart failure can either complicate and or be a complication of, right, ischemic heart disease. Then, yes, Shaheen, you are correct. The next one is arrhythmias. Arrhythmias. How can we get arrhythmias, Shaheen? Now, as you mentioned, arrhythmias, right? Arrhythmias. How can we get arrhythmias when we have a myocardial infarction? What do you all think? Any idea? Any clues? Just think about, guys. Just come up with hypotheses, okay? This is what I want to do with you all, okay? Come up with mechanisms of how things can happen. Then we'll figure out if that is what we found out so far today, or maybe you all are on the way to some research work. Huh? Okay? That is how I want her to think. Huh? What do you all think?
The necrosis could have
The
led this.
necrosis. Okay, necrosis causes what? How can the necrosis give rise to an arrhythmia? Good, you're on the path.
Maybe the ectopic beats.
Ectopic beats. Excellent. This is Ayush, yeah? Ayush, which year are you from?
Third year.
Third year. Good. Which university?
Nanjing Medical.
Nanjing Medical. Okay, excellent, excellent. Okay, look at this. Good, huh? Proud alumnus. Huh? Okay, look at this. Here, guys, today we'll talk about the blood supply of the heart, right? We'll talk about the blood supply of the heart, right? The coronary circulation specifically. You all know, in the heart, guys, here in the right atrium, we have something called the SA node, right? Then from that, we come to the AV node. And from there, we have the bundle of His, the Purkinje system, right? This is how our heart is, no? The conduction system of the heart. Now, there are some infarctions, guys, specifically, if it is coming from, we'll talk about the blood supply, don't worry. If any infarction involves this right, specifically the right atrial area, right? Any infarction coming there, or any infarction coming to this AV nodal area, right? When these areas are infarcted, guys, there is no one in the heart to begin a electrical impulse, because SA node is the primary location where electrical impulses start, right? Now, if they undergo infarction, right, we'll talk about the specific vessels involved. There is no one to start the impulses. So what is happening is, guys, our heart is, there is a very special physiology in case the SA node or plus or minus the AV node is also not working. They are not functional. Our heart in the myocardium itself, it starts firing what we call ectopic focuses, right? Ectopic foci, right? These places start impulses. They generate their own impulse. Now, the SA node, usually, guys, you all know, generates impulses at a rate of 60 to 100 beats per minute. But these areas, they don't generate at that rate. Some areas will generate very rapid ones. Some areas will generate very slow ones, right? Less than 30 sometimes beats per minute, right? However, just to keep the heart pumping, these areas will generate impulses. And those ones will give rise to arrhythmias, right? Because they are not generating nicely, steadily in the 60 to 100 beats per minute. Okay, they are generating however they want, right? Okay, so it's like chaotic. They generate signals chaotic, right? In various directions also, right? Now you all know the SA node, when it gives out signals, guys, that major depolarization direction is like this, right? We'll talk about this in the ECG. It's leftward and it's downwards and to the left. This is the major ventricular depolarization direction, right? But when you have these ectopic focuses, they give electrical impulses in various directions, right? Here, very chaotic. Okay, so this is why even if you do the ECG, you will see abnormal arrhythmias in these patients. You can see arrhythmias in these patients. Okay, right. So clear about that. So these are some complications. Apart from this, guys, again, when they have heart failure, right? They can have tachyarrhythmias. Tachycardias also can be sometimes. So when you will check the pulse, you will want to check the pulse of these patients. We'll talk about the physical examination, right? So these are the basic complications that we want to exclude, right? And if anything is present, we have to simultaneously manage those as well. Okay, simultaneously manage those as well while we are managing the acute coronary syndrome. Everyone clear up to this point, right? Okay, all good, right? Then, so what have we done? We asked about the chief complaint, right? We analyzed the symptoms, right? Then we excluded some differentials. We asked about the current management, what has been done after the patient came to the hospital, right? And then we asked about complications, right? Then, guys, another small thing we want to do is we want to ask about any comorbidities. This is the next one, any comorbidities. What do we mean by these comorbidities? these risk factors, guys. Right? Yesterday, you remember we talked about some risk factors that can give rise to this entire ischemic heart disease. What did we talk about? Diabetes, hypertension, dyslipidemia. Ask about these. Have you been diagnosed diabetes? Right? Are you a diagnosed hypertensive patient? How long has it been? Are you on medication? What medicines are you taking? Sometimes the patient knows the medicine. Right? What medicines are you on? All these questions, right? You have to ask. Okay, clear? Clear? Right. Then what is another very important question you have to ask about comorbidities? True, you have to ask about diabetes, hypertension, cholesterol. Even before that, what is the first question you should ask? Sorry, I forgot that. Have you had this kind of a condition before? Right? You have to find out if this is a already diagnosed patient with ischemic heart disease coming with a second presentation or a third presentation. We don't know. Right? Must ask. You can never miss that. Okay? Right. Then apart from that, guys, what are the other risk factors yesterday we talked about? Are you a smoker? Right? Are you a smoker? If we say, yes, I'm a smoker, what is the next question? What is the follow-up question? If they say I'm a smoker, what do we ask? Now I'm the patient. You all ask questions from me. I am a smoker. Okay. What's the next question?
How much do you smoke in a day?
How much do I smoke in a day? How many cigarettes do I smoke in a day? Okay. I tell you, I smoke 20 cigarettes a day. What is your next question? What is your next question?
How long have you been smoking?
How long? Okay. I'm telling you, I have smoked for 2 years. At least 20 cigarettes per day. Now, what can you do with this information? What can you do with this information?
Calculate the pack years.
You can calculate the pack years. Excellent, right? So this is usually what we call, so one pack per day taken for 1 year. We call it 1 pack year, right? 1 pack year. Okay. So 1 pack means how much? 20 cigarettes, right? 20 cigarettes. Huh? I know this because I have studied, nothing else, right? So 20 cigarettes per day for 1 year will be 1 pack year. So this, what did I say now? 20 cigarettes per day for 2 years. So how many pack years am I? How many pack years am I? 2 pack years, no? Okay. Okay, maths. Maths genius, a little weak, no? In me, not in you guys, I am very bad at math, guys. Okay, confession. Okay, anyway, I cannot survive without a calculator. Anyway, right, let's move on. Right, so you ask about smoking. Next thing, alcohol. Alcohol, what should you ask? How many times do you drink a day? Here, guys, specifically in our South Asian region, you have to ask, right? Not just South Asian region, even in other places, you can ask, do you take any, okay, first you ask, how much do you drink? How much do you drink, right? You can ask, do you drink daily or do you drink once a week, twice a week? What is the regularity? You have to ask that first. Then you have to ask, what kind of alcohol do you drink? Because, guys, specifically in our regions, right? We have the factory manufactured quality alcohols, as well as we have what we call kasippu, what we call, these kind of things are there, no? Illicit alcohols. So you have to ask about those also, because they come with other disorders like amoebic liver abscesses and things like that. So you have to get rid of all of those. You have to ask all of those questions, right? So what types of alcohol do you consume? Okay, right. Then, so those are some comorbidities, and to ask if they are, guys, if they say, okay, I'm a diabetic patient, you have to ask when did it start? You have to ask everything, right? When were you diagnosed? When were you diagnosed? What medications are you on? Are you only taking oral medications or are you taking insulin as well, right? So you have to ask, sometimes the patient might know if he's type 1 or type 2. So you can ask that. These kind of questions you must ask, okay? And you have to ask about the control of diabetes, right? Now you all know, guys, diabetes. What are the complications when we have diabetes, guys? What are the complications of diabetes? Huh? What are the complications of diabetes?
Retinopathy.
Good. So retinopathy. Okay. What else?
Neuropathy.
What else?
Nephropathy.
Okay. Anything else? So here we have, guys, you're correct. Excellent. Excellent. So we have microvascular complications and macrovascular complications, right? So we have the microvascular is the small vessel. So the retinopathy, the nephropathy, right? Neuropathy, these kind of things, right? And then we have some macrovascular ones also, like peripheral vascular disease, right? You have to ask about all of these conditions. Don't worry, diabetes is another class under our endocrinology module. We'll discuss that later, okay? Some of you might have joined my previous diabetes class, right? We'll talk about that in a different day. Then, any other thing you want to ask about from this patient? Now, you all know, guys, when it comes to treatment, yesterday also we discussed, almost all the patients, we put them on a beta blocker, right? We put them on a beta blocker, if you all remember, right? Here, guys, with regards to the comorbidities, it's important that you ask if the patient is a diagnosed asthmatic, right? You must ask, have you been diagnosed asthma? Because there is a problem, we cannot, right? We have to prescribe very narrow spectrum beta blockers. Usually, if the patient is a severe asthmatic, we cannot put them on beta blockers. Okay, right? So that question you have to just ask, have you been diagnosed asthma before? Okay, right? Right. Then, so we have asked about the comorbidities. The last question, last component in the history taking, guys, that I want you all to be familiar with. Just ask about any family history. Any family history. Is there anyone in your family who has had this kind of a condition before? Any first degree relative who has had this kind of a condition before? Is there anyone who has had a heart problem at a young age, right? Young onset heart disease, right? These are the specific questions you must ask, right? Is there anyone, have you heard something called familial hypercholesterolemia, right? Sometimes these patients know, right? You can ask, is there anyone in your family who has had hypercholesterolemia since the young age, right? Okay, right? So these kind of questions you must ask the patient. That is our basic history taking, guys. Okay, that is our basic history taking. Now we don't spend all of this time asking all of these questions, guys. In the emergency setting, if you go to take all of this history, what will happen to the patient? Patient will go up and you will come down. You will be demoted, right? Okay, so you don't waste time asking all of these questions. You just ask a few depending on the scenario, right? Obviously, if the patient is well rested and he's fine, you have a little bit more of a time window. Usually, we will not ask all of these questions, right? But some important questions you have to ask. For example, the type of the pain, right? About the chief complaint, you must ask. You must try to differentiate, right? So these kind of things are there, right? Right. So that is the basic history take. Now I'm going to ask you all questions and I want you all to answer. Okay. Now it's a question discussion. Okay. Right. Now I'm going to ask you. Okay. I am your examiner now. Okay. I'm your Viva examiner. Now you have come for the Viva exam and your case is a patient, let's say 55-year-old patient, diagnosed patient with diabetes, right? Hypercholesterolemia for the past 20 years, presenting with acute onset, central type of chest pain with sweating, diaphoresis, and presenting to the hospital, right? He has come to the hospital after, let's say, 2 hours since the onset of pain. Okay. Now, I am asking you all tell me, right? What do you want to examine in this patient? Examination. What do you want? Physical examination. What do you want to examine in this patient? Tell me one by one. Just whatever comes to your mind. What do you want to examine in this patient? What do you want to first check, guys? When there is a patient coming with this acute onset chest pain, what do you want to first check? What do you think?
The vital signs. We start with the vital signs.
Excellent, excellent. So we can start with the vital signs. Good. What specifically are you talking? What specifically do you mean when you say vital signs?
We're checking for the pulse, the SpO2, the blood pressure.
Right. Look at this, guys. Pulse. Excellent. I agree with this. Pulse. Right. Specifically, guys, in acute coronary syndrome. Now, Shaheen, I agree with you. You're good. Whatever the vital signs, we have to check in all of the emergencies, right? All of the emergencies, one of the first things you check is the vital signs. I agree. Coming to specifically acute coronary syndrome, there are certain things we need to initially check, right? These are the first things that you should check. One is the pulse, right? The other one, guys, you want to check if the patient is still in pain. We'll talk about why, right? Patient is still in pain. And the other thing, right, you want to check if the patient has any pallor, right? We check from we pull down the patient's lower palpebra and you check if there is any pallor, right? Why do we do this? Pulse. Why do we check the pulse, guys? We want to make sure that the patient has not progressed or complicated with any arrhythmia. Now, previously we talked about complications. There was arrhythmias. No, we want to make sure there is no arrhythmia. This is why we are checking the patient's pulse. Pain. Why do we want to know if the patient is still in pain or not? Why? Is that important? Why? What do you all think? If the patient is still in pain, do we want to do anything about it, or can we be like, nah, that will go away, don't worry, we'll treat you? What are you going to do? What can we do? Or why are we looking at this pain? You all know, guys, pain. When we talk about pain, there is something called our fight or flight response, our sympathetic system. When there is pain, guys, our sympathetic system gets activated, right? Sympathetic system gets activated, right? So whenever our fight or flight mode, whenever our sympathetic system gets activated, what happens, right? Our blood pressure increases, our heart rate increases, right? What has happened? Our cardiac output will also increase, right? Our basal metabolic rate will increase, BMR increases, right? These kind of things happen with the sympathetic overdrive. Now, if these things are happening, what does our heart need to do all of these things? More and more oxygen, right? More and more oxygen. But what is the problem? We don't have oxygen, right? Acute coronary syndrome, it's a ischemic heart disease. So what are we doing, guys? If the patient is in pain and we are not managing that, due to this sympathetic overdrive, this can further exacerbate the ischemia, right? It can further exacerbate the ischemia because the oxygen demand by the heart will be high, right? The demand by the heart will be high. Okay, clear about that? Understood? Right. Then pallor. Why are we talking about pallor, guys? Pallor, guys, mainly, when do we get conjunctival pallor? Huh? Some of y'all also might be having, especially if you're like indoors all day studying, not going out into the sun a little bit. Might be having some conjunctival pallor, right? Anemia, right? Anemia. Why we are looking for this is, guys, if the patient is anemic, right? Pre-existing anemia, this can worsen ischemic heart disease. This is obvious, no, guys? Ischemia is happening, so we don't have oxygen as well. If the patient is already anemic, right, this can worsen ischemic heart disease, right? So these three things we need to initially check, right, and rapidly manage, right? Rapidly manage. We want to check them first and manage them as soon as possible. Okay, everyone agrees, right? Then, yes, Shine, you're correct. Then we look at the other vitals as well, the respiratory rate. We'll talk about pulse oximeter and all when we come to the specific management, right? We connect the patient to the cardiomonitor. We'll talk about all of that. Okay, these three of the main things that we want to do first, right? Next thing. Next, what do you want to do? Next, guys, we are looking at some other risk factors as well. So, for example, what was one of the primary risk factors for ischemic heart disease? Dyslipidemia, mainly hypercholesterolemia. That is, the bad cholesterol is elevated and the good cholesterols have dropped, right? This is our dyslipidemia. So we want to look for what we call peripheral stigmata of hypercholesterolemia, right? Peripheral stigmata of hypercholesterolemia. Let me show you all some. So here we have mainly three, guys. See if I can. Can you all see the screen? Hey, you all can see the screen, right? Yeah, right? Look at these guys. We have tendon xanthomas, right? Xanthosoma, right? What we call in the palpebral fissure, the upper palpebral fissure, there is like a cholesterol fat deposit, right? Then we have corneal arcus, right? Corneal arcus. This, if you can see here, right? Corneal arcus, right? So these are, don't worry, I will send this PDF in the group. So we have, these are the main three that we are looking for, right? Tendon xanthoma here, guys, within tendon sheaths, there is cholesterol deposition within the tendon sheaths, right? So these three are the main things what we are looking for, right? Main things what we are looking for. Here, I forgot to show you all these, some marfanoid features, right? This is what we call a high arched palate, guys. High arched palate here. The palate is very, if you all have seen, right? You just put a torch into the oral cavity, tell them to say and you check, you can see a high arched palate. Then this is the thumb sign, right? The thumb sign here, right? And you have the wrist sign, right? They can envelope their entire wrist using the thumb and the little finger, right? So these are the arachnodactyly, right? These kind of features are there, right? They can have some scoliosis, right? All of these you can look for, right? Don't worry, I'll share this PDF, Right. Then, next, right? Apart from that, You can also look, we talked about the DVT, so you can see if there is any unilateral limb swelling, right? Any ankle edema, these kind of things you can talk about, right? Then guys, so that is basically the general examination. Then we specifically come, you all are done writing? Still writing? All good? Right. Look, next we specifically come to the cardiovascular examination, guys. Now, cardiovascular system, CVS proper, right? CVS examination. Here, what are we going to check? We talked about the pulse before, right? So we check the pulse because we want to make sure the patient does not have any arrhythmias, right? The next thing, guys, another thing we want to check for is we want to check the heart rate. We want to see if the patient is adequate, because sometimes if they can have compensatory tachycardias, they can even have bradycardias, depending on how severe the heart rate is, right? So we want to look at the heart rate as well, right? And guys, why another reason we are checking the heart rate, they can have what we call heart blocks, right? Specifically, right? Depending on where the infarction is, specifically if it is near the SA nodes, right? If it is somewhere in the Purkinje, now we are going to talk about a left bundle branch block. That is another type of block. Then we have first degree heart blocks, second degree heart blocks, right? All of these, whatever, depending on the location of the infarction, these manifestations can occur. Don't worry, we are going to talk about in depth the ECG findings and all. Right. Then another thing, we want to, now you all know in your cardiovascular examination, right, in the CVS proper, what are we first doing? We are looking for the apex. We are looking for the apex beat, and we are trying to palpate and locate it with one finger, right? This is what we usually do now, right? If the patient is here like this, we first go to the foot end of the bed. All right, we check if we can see any visible apical beat. If we can't, we put our hand, right, and try to locate the apex with one finger. Usually, where is the apex, guys? Usually, where is the apex? Where is the apex? Left, in the left fourth intercostal space, just medial to the mid-clavicular line, right? This is the usual apical beat, right? So you want to see, what are we looking for? This is the usual apex. The cardiac apex is somewhere here. What are we looking for? We are looking for any probability of a deviated apex like this. The apex beat is somewhere here, right? So this deviated apex can occur in multiple conditions, guys, right? We're not going to talk about those today specifically, right? But you all should know if there is hypertrophy of the heart, right? Specifically if there is heart failure, right? There can be a deviated apex, right? Also, some valvular heart defects will come with a deviated apex. We'll talk about that in a valvular heart disease class, right? So that's another thing you're going to look for. Then, okay. What is another complication we said, guys? Remember pericarditis? We talked about pericarditis. What sort of physical examination findings can you find in pericarditis? Okay, physical examination, I mean auscultation. Let's go to auscultation. Auscultation. What are you going to see in auscultation of the patient? Firstly, if there is pericarditis, what are we listening for? What are we looking for? Any idea?
Pericardial friction rub.
Excellent. Pericardial friction rub. What is this pericardial friction rub, guys? This is a high pitch, like a scratching like sound, like a grating sound, right? That you hear when you place the stethoscope, right? Because the wall of the heart is rubbing against the inflamed pericardium, right? This is what we call a pericardial friction rub, right? Like a grating sound. Okay. Then, apart from that, on your auscultation, what else are you looking for now? Now think about everything that we have discussed in the acute coronary syndrome, including the complications. What else can we possibly listen for in our auscultation?
Possible murmurs.
Possible murmurs. Excellent. What is a possible murmur? What is a possible murmur? We mentioned a little while ago. Guys, anyone?
For mitral regurgitation, if there is, we can get some pansystolic murmur.
Right. Excellent. So mitral regurgitation. Good. Pansystolic murmur. Pansystolic murmur, describe it to me better. Pansystolic murmur heard where? Radiating to where? Juniors, don't worry. We will have a full valvular heart disease session. Very interesting session. Don't worry. Okay. Mitral regurgitation, guys. All right. This is the mitral valve. It is heard best in the right? Best in the mitral regurgitation is heard best where? At the
apex.
At the cardiac apex, right? And where does it radiate to? Mitral regurgitation, guys, the murmur radiates to the axilla. Murmur radiates to the axilla. Okay? The mitral regurgitation murmur is a murmur best heard at the apex, radiating to the axilla. And mitral regurgitation is a left-sided or a right-sided murmur. It is from the left heart or the right heart. Mitral regurgitation. It's from the
Left.
It's from the left heart. What do you all know about all left-sided murmurs? It is significantly increased on what? On expiration and holding the breath. So you have to check. This was actually in my final MBBS Viva. This was my case. This was my short case, right? Mitral regurgitation, short case. So it was a 80-year-old lady, 80-year-old Archie. So they were like, do the cardiovascular examination. Very clear murmur, right? Very nicely heard murmur. The problem is with all the excitation, I forgot to check the radiation, right? And the examiner was like, did you check the radiation? And then luckily, so you all know, Sri Lankan students, you all know for the short case, you all get 6 minutes, right? 6 minutes and 10 minutes discussion. Like that, no? 6 minutes plus 4 minutes discussion. So 6 plus 4, 10, right? The short case is 10 minutes. So within that 6 minutes, you have to finish your examination. So luckily, I finished my examination within about 4.5 minutes. So I have missed the radiation and all. So they were like, did you check the radiation? I said, you never lie to the examiner, right? Never lie. Because they were watching, they know what I missed, right? And so I said, sorry, sir, I forgot to check it. Then go check it again. You have time. So I went and I checked it again. Very clear cut. You can hear the radiation nicely, right? At the apex. Okay. So anyway, we'll never forget that. Right? So, MR murmur heard best at the apex, radiated to the axilla while the breath is held on expiration. So you tell the patient, take a deep breath, send it out, expire it out, and then hold it while you auscultate. Now that also, guys, you do it for a very short period of time. Otherwise, the patient will collapse. Okay. You don't tell them to hold and wait and you are listening nicely, auscultation. No, you listen quickly and you tell the patient, okay, thank you. And you let them breathe again. Okay. All right. Right. Then, so that's mitral regurgitation. Then, guys, anything else you want to listen in auscultation? Anything else that we talked about? What do you all think? Today we talked about heart failure as a complication of acute coronary syndrome. Now, if there is heart failure, what do you want to listen to in your auscultation? Anything you all know?
Some crackle in the lung could be.
Yes, you can listen for some crackles in the lung. Okay. More specifically, if we're talking only about the heart, yes, you're correct. Bibasal crepitations in the lung, you can auscultate for. Specifically, we like to check in the back, right? We'll check that in the back. In the front, specifically related to the heart, what do you want to look for? Have you all heard something called a gallop rhythm, guys? Gallop rhythm, right? There is something called a S3 gallop. S3 gallop. What is this S3 gallop, guys? What is this S3 gallop? Now you all know. I'll quickly teach it. These are heart failure chapter work, but let me just, so that you all are not incomplete. I don't like this incomplete knowledge, right? Look at this, guys. Look at this. If we have a patient coming in with heart failure, right? Or ischemic heart disease, acute coronary syndrome complicated with a heart failure. Now what is happening? This heart cannot pump out blood. This left ventricle will not pump out blood, right? So the cardiac output and everything will be reduced. So there is a relative stasis of blood in the left ventricle, right? Then there is also, because this blood is not going out, in the left atrium also there will be a stasis of blood. Little by little with the congestion, the pulmonary veins, right, will also be having stasis of blood, right? And then the lungs, this is why we hear the bibasal crepitations, right? The lungs will also be having some pulmonary edema. And then finally coming all the way to the pulmonary arteries, right? The pulmonary circulation, and then coming to, this is what we call, when a left heart failure progresses to the right heart failure, what do we call it? Congestive heart failure. Don't worry, heart failure is a big topic. We'll discuss that later in detail. But now what I want you all to know, when there is congestion of blood like this, right? When there is congestion of blood like this, right? There is a blood build-up here, and there is a lot of blood build-up here also. With every diastole, you all know, guys, with every diastole, right? As these bicuspid valves open, there is a large volume of blood coming into the ventricle. Large volume of the blood coming into the ventricle from the atrium, right? Large volume of blood. When this large volume of blood comes to the large volume of blood comes to the ventricle and it hits this ventricular wall. It hits this ventricular wall. We hear a third sound. We hear a third sound. This is what we call the S3 sound, right? S3 gallop. S3 gallop. Okay. All right. Then there is the S4 sound also. We'll talk about that later. Okay. Right. For now, just know this S3 gallop. Okay. Right. Then, next thing. Now, let's say there is heart failure. What is happening? Left side, there was a lot of blood build-up, congestion, pulmonary edema. Then coming to the right heart, right? Here, the right ventricle will also have a lot of blood. In the right atrium will also be congested. What is bringing blood to the right atrium, guys? What is bringing blood to the right atrium? Our superior and inferior vena cava, right? Superior and inferior vena cava. So when the right atrium is congested, what is happening? Superior and inferior vena cava also gets congested. Agreed? Here, what is the physical examination finding you will see when the superior vena cava is congested? The patient's neck veins, right? This is the patient's face, right? The neck veins start getting distended. Neck veins start getting distended. Okay, this is the superior vena cava. Huh? Okay, so we have the jugular vein. Jugular veins start getting distended. Then another thing, inferior vena cava, you all know, here we have the liver, right? Here we have the liver. So what is happening? There is going to be portal congestion, right? And then eventually, right, all of these systems are going to be congested, guys. Heavily congested. We'll talk about congestive heart failure, very big chapter. But what you are going to see, sometimes now when there is blood filling in these ventricular chambers, what is this valve, guys? In the right side. So here we have the bicuspid, or the mitral valve. This is the tricuspid valve. Tricuspid valve, right? So when there is a blood overfilling in this left ventricular chambers, in the right ventricular chambers and the right atrial chambers, what is happening? These valvular functions also start getting abnormal. Sometimes they can even regurgitate, guys. They can even regurgitate. Why? Too much of blood. Too much of blood in the chambers, right? So when these valves regurgitate, guys, right, with every beat of the heart, if the valve is regurgitating blood, this blood will come and hit on the liver. It will come and hit the liver, right? So there we get something called a tender pulsatile liver, guys. With every beat of the heart, the liver goes down a little bit. Right? This is called a pulsatile liver, and there will be tenderness. Why? There is a lot of blood building up and there is inflammation as well. We'll talk about this later, right? How those happen, we'll talk about later. Right? So if there is heart failure in the cardiovascular system, auscultation, you are going to listen for a S3 gallop. Physical examination, you can look for elevated distended jugular veins and a tender pulsatile liver. Okay. Apart from that, pedal edema, all of those features you can look for. Okay. Right. Everyone clear after that? Right? Right. All good. Give me a thumbs up. Because now we are done with that basic component. Now we are going to the management part. Okay. Right? Okay. Right. Okay, right. Again, let's do some discussing, right? Now, how are we going? We come to the management, right? How are we going to manage, right, acute coronary syndrome? This is our next question. What is this, guys? Acute coronary syndrome is a medical emergency. So what is our first sentence? My history taking, examination, and the management, diagnostics and the management will go simultaneously, right? This is your first statement. Then, now we come to the specific management. If it is a medical emergency, guys, do we want to treat this patient in the outpatient department? Can we? No, right? So either, depending on the facility availability, we will put the patient, either admit them to the intensive care unit or the high dependency unit, right? In Sri Lanka, we have this concept called the acute side bed. This is usually the first bed just next to the consultant's room. Okay. I'm not sure about other countries if they have the same concept, but whatever it is, you say you have to admit this patient. This is the first step. Admit the patient to the high dependency unit or the acute side bed. side bed, or if you're in a base hospital where ICU and everything is available, you put the patient to the ICU. Right now, for example, so I studied in Nanjing, right? Acute coronary syndrome, straight to the ICU. Okay, they don't check for anything else, straight into the ICU. Okay, right? Except for there are some exceptions. For example, if there is a non-STEMI, they will think twice about ICU. They will put them to the high dependence unit, right? But majority of the patients, because they have enough beds, right? Not like our countries, right? So high dependence unit or acute side bed or ICU, right? Depending on facility availability. Then what are you going to first check, guys? You are going to check the airway, breathing, and the circulation, right? Because this is a medical emergency. As with all medical emergencies, check the airway, breathing, and circulation. Now, how are you going to check the airway? How are you going to check the airway? Guys, let's discuss, right? How are you going to check the airway? Unmute and say, just what are you going to do? When we say airway, breathing, circulation, how are we going to check the airway? Okay, now I'm your patient, right? I'm coming now. I'm on the hospital bed, right? I'm being brought, right? And I'm like, hi, doctor, Prashan, right? Any clues about my airway? If I am talking, my airway is fine. Okay. If the patient is talking, airway is fine. Okay. Right. That is your first point. If not, you need to check. Open the oral cavity. You check the nasal cavities. You check if there is any secretions, any fluid. You will suck them out. Right. Majority of the time, patient is usually able to communicate with you. Right. Right. That is airway. Breathing. What are you going to check? What are we checking? Tell. Answer. I'm waiting for an answer now. Breathing. What are we checking? Huh? Tell. I'm waiting for an answer. What are we going to check? Guys, actually, it's a little bit tiring. That's why. Okay, I'm taking a small break. Tell me, what are we going to check in the breathing?
The respiratory rate, any abnormal breathing sound like wheezing, straight
Excellent.
up.
That's it. Look for labored breathing, right? Use of accessory muscles, intercostal retractions, any stridor. Yes, excellent, right? And any abnormal breathing signs. Respiratory rate, how are you going to look? One thing, you can look at the respiratory expansion. You can check if the patient's chest is expanding as they breathe. If not, there is a problem, right? Very simple things, right? Okay. Then later, the next step, we'll put the pulse oximeter and saturation. We'll check. So A, B, C. What is C? Circulation. What are we going to check in the circulation? For the circulation, guys, we can check the pulse. Physically, we can check the pulse. But apart from that, usually we need to connect the patient to the cardiac monitor. Right? So cardiac monitor, what are we going to check? Right? That will show you everything. Right? The cardiac monitor will show you everything. The blood pressure, systolic pressure separately, diastolic pressure separately. It will even show you the heart rate with relation to the respiratory drive. So you will see the respiratory waves going like this. With that, you will see the heart rate, the ECG line going like that. Right? You will see everything. Right? We'll discuss this in our arrhythmias chapter. I have taught this previously to some previous students. We'll talk about that in an upcoming chapter. Right? Then, so what did we do? We connected the patient to the cardiac monitor. Here for the breathing, we also connect the patient to the pulse oximeter. This pulse oximeter is a very small one. We put it on the finger. Wait, I have a picture, I think. Yeah, you can see this. Yeah, there we go. Okay, so here we have. So this is a cardiac monitor, right? This is a cardiac monitor, right? And here this is the pulse oximeter. This cardiac monitor, guys, all these readings, right? I will teach you all. Okay, this is not today's class, but we will learn how to read the cardiac monitor, don't worry, right? And this is a pulse oximeter, right? Right. Then, so we connect the patient to this. Now, what are we going to do? In the pulse oximeter, guys, you can see the patient's oxygen saturation, right? If the saturation is less than 90, right? Usually in pediatrics, guys, if it is less than 92, we start treatment. If in adults, usually 90 is okay, right? Usually if the pulse oximeter saturation is less than 90, we put the patient on high flow oxygen, okay? Put the patient on high flow oxygen. How do we give high flow oxygen? Usually nasal cannula or a face mask, tightly fitting face mask, right? Okay, right? Now, after this initial management, guys, our immediate next step is order an ECG. This is very important. right? After these immediate things, even before starting the patient on any other medication, order an ECG, right? We want an inward ECG, guys. We don't want to take the patient somewhere to the next ward where the ECG machine is and do that. No, inward ECG. They should bring the ECG machine to the patient. The patient is there in the ward itself and you do the ECG. Okay. Urgent inward ECG. Okay. Right. So until the ECG results come, there are a few things. Now, while you can get either the ECG technician or someone else can come and help you place all the leads and, the limb leads. We'll talk about ECG today. Don't worry. Until all of that is done, you have a few other things as the medical officer. You have a few other things to do, right? So at this time, specifically when we are preparing the patient for this ECG, and during that time, you have a little bit of a free window to ask some questions from the patient, right? Ask some history, right? We said the history and the management goes together, right? So this time you can use to ask some history. Then you can also use that time to draw some blood, right? You can draw some blood for some basic investigations. What do we mean by basic investigations, guys? We want a full blood count, right? Full blood count we can check. Then since dyslipidemia is a high risk factor, we can do a lipid profile. Lipid profile. Here, why are we doing the full blood count, guys? Mainly, we are looking for any signs of infection, right? And anemia. These are the two main things we want to look for. Infections and anemia, okay? So, elevated WBC and reduced hemoglobin. These are the main things. Then we can check a lipid profile as well, right? Apart from that, we also want to check the serum electrolytes. Serum electrolyte panel. Why? Specifically, guys, if we have to manage something like a comorbid heart failure and all, this will come in very handy. So we need to check the patient's electrolytes, right? Then yesterday we talked about the diagnostic investigation that we do from the blood. What is that? Our troponins, right? We can also order blood for troponins, specifically troponin I and troponin T. These are the most specific ones. Out of that also, guys, now yesterday we mentioned something called high sensitivity troponin I. High sensitivity troponin I. Usually, guys, troponins, we said, usually it takes about 4 to 8 hours, right, to start rising up. 6 to 8 hours usually. But this high sensitivity troponin, this can show results even within 1 to 2 hours, right? Very sensitive, right? So we can do this immediately, right? We can do this immediately. Right? Clear? Then, guys, now still, right? Still they're preparing for the ECG and they're doing the ECG on the patient, right? We have a little bit more time, right? What are we going to do? We are going to start our step doses. What we call our stat doses, right? Okay. What are these stat doses? You must memorize. Now, in medicine, guys, right? Majority of the content, I don't want you all to memorize. I want you all to understand. When you understand something, it's easy to keep going because you all will realize for your exams, whatever you memorize. Now, there are many 4th year, 5th years here, no? Once you all memorize something for the exams, just 1-2 days before the exam, after about a week, there is that stuff. All in the exam paper itself, gone to the department to be corrected, right? All of that stuff is gone. So what I want you all to do is understand concept. But there are certain things in medicine we must memorize. One is these things like this, the stat doses. You must know. Okay, must know. Right. What are these stat doses, guys? Look at this. I think I might have put it in your note. Have I put it in your note? Yeah, I have put it in your note, right? You all can go through your note. No need to write down. So there is aspirin, 300 milligrams stack. Clopidogrel, 300 milligrams stack, right? Atorvastatin, 80 milligram stack, right? Stack. Okay. Aspirin, clopid, atova, right? Aspirin 300, clopid 300, atova 80, right? Then, apart from that, we put the patient also for the painkiller. For the painkiller, we put the patient on IV morphine, right? IV morphine drip, right? Usually, guys, we go with 5 milligram, right? 5 milligram. Usually, depending on the pain, sometimes we can add GTN as well. Glyceraldehyde trinitrate also can be added if the pain is not being managed well. But usually with morphine, majority of the patients, their pain goes away, right? What is the problem with morphine, guys? Whenever we put the patient on morphine, right? Whenever we put the patient on morphine, they can get nausea. They can get vomiting, right? So because of that, we also add domperidone. You all know metoclopramides, right? Something like domperidone, right? Domperidone, right? IV, we have to go IV, metoclopramides, right? Something like domperidone, all right? This one usually about 10 milligram dose is enough. Okay, these stacked doses you must. Okay, everyone clear? Aspirin 300, clopid 300, clopidogrel 300. Yesterday we talked about clopid. I hope you all remember how it works. The glycoprotein 2B, 2A, glycoprotein 2A3B, right? Right. And then aspirin 300, clopid 300, atorvastatin 80, right? Morphine about 5 milligrams, and metoclopramide about 10 milligrams. Know these 5 medications. You must know. Right. Then the next thing, right? Some patients, guys, specifically recently we have found some patients are resistant to clopidogrel. Okay, some patients are resistant to clopidogrel. What do we give them? If the patient is resistant to clopidogrel, what do we give them? We have some newer medications, guys, right? Newer medications. So write this down. One is called prasugrel. Another one is called ticagrelor. Ticagrelor. What are these? What are these medications, guys? Prasugrel and ticagrelor. These ones, guys, now you all know our platelets. Our platelets are usually nicely sleeping, guys. Okay, platelets are nicely sleeping. Okay, usually platelets need to be activated for them to start coming and forming clots and thrombus formation, right? Now, how are these platelets activated, guys? Usually there are some receptors, right? Platelets have some receptors, right? These are called P2Y12, right? P2. Now, no one will ask these in your exams, but for you all to understand, these are called P2Y12 receptors, right? P2Y12 receptors. These P2Y12 receptors, guys, they have the binding site for ADP. You all know ADP, no? Right? ADP, right? So whenever ADP comes and binds to these P2Y12 receptors, these platelets get activated. Okay, platelets get activated. Okay, that's when they can start forming the clots. Okay, now what does prasugrel and ticagrelor come and do? Right? They come and competitively bind. Right? They have their own molecules that competitively bind to these active sites. Right? Therefore, what happens? ADP cannot come and bind. ADP cannot come and bind. If ADP cannot come and bind, what will happen? This plate will nicely remain sleeping. Right? So prasugrel and ticagrelor, how they work is they prevent platelet activation. Okay? Prevent platelet activation. Okay? Clear? Right. Then the next thing. So everyone clear up to this point? All good? All good? Right? Okay. Right. Next thing, guys. What if the patient was a diabetic patient? Now let's say, okay, I'm your patient, right? I have come in for management of acute coronary syndrome. Now you put me on, send me for the emergent ECG, and you put me on the 5 stacked doses. Another thing that you should do, when you are taking the history, I am telling you, doctor, I've been a diabetic patient for the past 25 years, and I am on metformin and let's say sulfonylurea or something like that. Okay, some oral medications. I'm on oral medications. In an acute emergency, guys, do you want to keep giving oral medications to control the diabetes or control the sugar level in the patient? What do you think? Is it convenient for you as the physician when you're managing an emergent condition, right? Do you want to keep checking his blood sugar, then giving oral tablet? Again, if the blood sugar drops, you reduce, right? Again, you give another tablet. What do you think? It's very difficult. Oral is difficult. So in emergencies, specifically like in the case of acute coronary syndrome, guys, what we want to do is focus. Yeah. What we want to do is we want to put the patient on insulin, right? So if a diabetic patient, especially a diabetic patient who was on oral medications, right? Oral meds, we switch him to insulin just during that period of acute management. Just for that acute management, until his acute coronary syndrome is managed, we switch him to insulin. Then later we can switch him back to oral. Okay, understood? Right. Now, your ECG results have arrived. Your ECG results have arrived. What does this mean, guys? The remainder of your management will be depending on this ECG, right? The remainder of the management will depend on the ECG. What are we looking for in our ECG? Now tell me, what are we looking for in our ECG, guys? In the case of acute coronary syndrome, what are we expecting to find? Yesterday also we have discussed. What are we looking for? One is ST elevation myocardial infarction. Another one is left bundle branch block, new onset left bundle branch block, right? Another one is non-ST elevation myocardial infarction. And the last one is unstable angina. Unstable angina is the same, guys, right? Same non-ST elevation in the ECG. They are both going to appear as non-ST elevation. This MI portion is how? Our biomarker, right? Unstable angina, right? So these are the four conditions. These are the four conditions. Look at this, guys. Let's talk about this ECG. Now, today, I'm not going to do a full ECG class for all, but there are some basic concepts I want you all to understand, right? Okay, so listen with all the layers of your cerebral cortex. Okay, look. Little bit complex, but stay with me, right? If there is any issue, let me know. Don't worry, we'll do a full-blown ECG later, okay? Look at this, guys. When we are looking at ST elevations, what did we talk about yesterday? There is something called the J point. The J point has risen above the isoelectric line. This much everyone remembers yesterday, right? Okay, all good. Right. Now, guys, I'm telling you all, this ST elevation doesn't happen at once. There is a sequence of events. So if we look at, let's say, a normal ECG, right? This is a normal person's ECG. Now, let's say this patient underwent some ischemia. The first and foremost initial change of ischemia is something like this, guys. Like this. There is what we call a hyperacute. This is the T wave. This T wave elevates. This is what we call a hyperacute T wave, right? Now, this hyperacute T wave, guys, this is a sign of ischemia, okay? You all might have heard another tall tented T wave in another condition. Where have you all heard about tall tented T waves in ECG? Huh? Any idea?
Hyperkalemia?
Excellent. Hyperkalemia, right? This kind of looks like that. But there are some subtle differences. Later we'll talk about, not today, but I will just mention hyperacute T waves, guys. They are tall, but they are broad. They are broad T waves, right? Whereas in hyperkalemia, the T waves, right, they are very, very narrow-based T waves. Okay, narrow-based T waves, right? So anyway, but now just remember that there is a slight difference, but it can look like a hyperkalemia. Okay, don't mix up the two. So this is the first sign, hyperacute T wave, right? Tall T wave. Then the next thing is, guys, now you all know this is the QRS. Q wave is very small. In a normal person's ECG, Q waves are very tiny, right? So what is happening, guys? Now, the next step is this S, right? The S here will also start elevating upwards. So it will look something like this, right? Like this, right? This S portion has also gone up now. The S portion also has gone up now, right? Okay. And then finally, guys, after some time, what can happen? This T wave can come back to the baseline and actually it can even invert. Sometimes the T wave can invert. Okay. These are the changes, right? Step by step. These things happen step by step. So depending on when you do the ECG in the patient, you might see any of these conditions, right? Any of these conditions. And the final one, guys, I will draw it here, right? Final one is something like, so we have the P wave and the Q wave starts developing, right? What we call a pathologic Q wave. And the ST will usually disappear. That ST elevation will start coming down now. After some time, the ST elevation will start coming down and it will show something like this. Right? Something like this. This is our pathologic Q wave. I will teach this, don't worry. Don't worry. Pathologic Q wave. What is happening here, guys? What is this and what is happening here? Look at this, guys. Usually, right? When we have, okay, let's talk about some basic concepts. The ECG wave. How is the ECG wave drawn, guys? ECG wave is detecting waves of depolarization. Waves of depolarization in the heart. What do we mean by depolarization? More positive, becoming more positive, right? So that you all know the resting membrane potential, there is something called minus 90 millivolts, minus 70 millivolts, right? We'll talk about those later. But whenever they become more positive, right? So if it was minus 90, if it goes to minus 40, that has become more positive, right? More positive. This is what we call depolarization, right? So positivity spreading throughout the myocardium is detected by ECG, right? It's detected by ECG, right? Now, the basic concept here is, if I draw the heart, something like this, right? If I draw the heart, something like this, and I'm telling you, right? We have talked about 12 LEDs in the ECG. We have talked about 12 LEDs in the ECG, right? But now we'll simplify that. I will say there is one negative LED here and one positive LED here. Just two LEDs. Just two LEDs coming and connecting to the ECG meter, right? And here, let me erase this. Right here, we have the ECG needle, right? This is the ECG needle, like this, right? ECG needle. Now, whenever we know the major ventricular depolarization, guys, it is downwards and to the left. Downwards and to the left. That means what? The depolarization, positive charges, positivity spreading towards the positive electrode. Correct? Everyone agrees? Positivity spreading towards the positive electrode. Whenever there is positivity spreading towards the positive electrode, this needle, guys, it will deflect upwards. It will deflect upwards. Okay, right? Now I'm telling you all, this ECG paper, right? Let's say this is the ECG paper. ECG paper is moving this way. ECG paper is moving like this, right? And this needle is deflecting up or down. This needle is deflecting up or down. So whenever, let's say now, the paper is moving like this, like this, like this, and there is a deflection upwards, right? Deflection upwards, right? So even what you will see is a wave like that. Okay, whenever positive charges are going towards the positive electron. Okay, these are basic I want you all to know today, right? Then whenever positive charge or depolarization in the heart is going away from the positive electrode, something like this, right? Positive charges going away from the positive electrode, what will we get? We will get a negative deflection of the needle. Negative deflection of the needle. So as the ECG paper is moving this way, moving like this, the deflection will be something like this. Okay, deflection will be something like this. This is the basis of ECG. Don't worry, we will go into deep in another class. Now, what do I want you all to understand? Look at this, guys. When we have a myocardial infarction, right? When we have a myocardial infarction, right? Let's say I'm telling you, this portion underwent myocardial infarction from here to here, right? Okay, here to here. Now, guys, that same principle, if we apply here, the negative electrode placed here and the positive electrode placed here, right? And we connect this to the ECG machine. Okay, right? How are we going to look at this, guys? Look at this. This is a step-by-step process. Now, we said, what is initially going to happen? There is going to be a tall T wave, which we call the hyperacute T wave. That is an ischemic change. That has nothing much to do here, but that is an ischemic change. Then we have the S portion also elevating up. And finally, T waves can be inverted and the Q wave can be formed. How is this Q wave formed, guys? Like this. Let's say this portion has undergone infarction. Who will come here? Who will come here? Macrophages will come. Neutrophils will come. Macrophages and neutrophils, they come here, guys, and they start eating into this necrotized area because there is necrosis going on, right? Whenever necrosis is going on somewhere, macrophages and neutrophils, they come, they eat and engulf these substances, right? Then, now macrophages and neutrophils come and eat into this area. And next, who is going to come, guys, right? Like you can draw it like a horse or something, right? He is carrying a lot of collagen. Who are these? What is the cell type that is able to come and lay down collagen? Fibroblast, right? Fibroblasts come to this area and they start laying down collagen in this damaged area. This is basically how our tissues heal, right? This is basically how our tissues heal. Whenever the fibroblasts come and deposit collagen, this collagen with time, it will contract and form a very, very sturdy structure, right? A very sturdy, right? Non-contractile structure here in this damaged area. Okay. So this is the basic healing process. Okay. Now, guys, look at this. If I draw a normal cardiac muscle, and I'm telling you, we put a negative electrode and a positive electrode, right? There is another principle I want you all to understand. In ventricular myocardium, guys, waves of depolarization always go from inward to outside. inward to outside, right? Inward to outside. Waves of depolarization in the ventricular myocardium always go from inward to outside. Inward to outside. Okay, everyone agrees? Now, if I tell you, right? If I tell you that there is, let's say here, point, let's call this point A, let's call this point B, right? What do you think? In a normal myocardium, this positive electrode will be able to detect A, impulses at A, or impulses at B, or both. What do you think? The normal myocardium. In the normal myocardium. Just don't think too much. The electrode is just there, right? Which impulses do you think this electrode will detect the most? Guys? A, right? Don't think too much. Don't think too much. So impulses at A will be detected by this electrode. Okay. And impulses at B will mostly be detected by this negative electrode, right? Negative electrode. So in a normal patient, no problem here, right? So what is going to happen when this positive electrode sees this impulse coming at A, it will show what? A positive deflection. A positive deflection, right? A positive. This is in a normal person. Normal person. Look at this, guys. Normal person. What is happening here? Here, guys, when we have a defect like this, especially a fibrosed portion, right? A fibrosed portion that has undergone fibrosis, right? After the collagen has been laid down, it has undergone fibrosis and scar tissue has formed. What is going to happen here, guys? This is going to act as what we call an electrical window. What do we mean that? It means it acts as nothing. It acts as like a piece of glass, right? It acts as a piece of glass. So what is happening, guys? This positive electrode now can sense impulses that are here as well, right? You all know impulses are always from outward to inward. Now what is happening? This positive electrode can sense these impulses as well. Can sense these impulses as well. So how will you see it in the ECG? Depolarization currents going away from the positive electrode. How do we see it? Upward deflection or a downward deflection? Upward deflection or downward deflection? Huh? Depolarization currents going away from this electrode. Why? This guy can see now. He can see these, right? So this is going to be a downward deflection. Everyone agrees? Downward deflection. Huh? Right? If it is a downward deflection, guys, this is why we see a deep Q wave, right? This is why we see a deep Q wave in the ECG. The problem is, now tell me this. Okay, let's say I had an infarction today. I had the myocardial infarction today. Will you see the pathologic Q wave today? Will you see the pathologic Q wave today, sir? No. Why? Yes, sir. Why not? Why not? Good. Why not? Just guess. Just guess. It's okay. Why do you think? Any clue? Guys, now what happened? Macrophages had to come. Neutrophils had to come. They had to eat all these. Fibroblasts had to come, lay down the collagen. Can these happen in one day? No. Right? These changes take at least 3 to 5 days. Right? 3 to 5 days. Right? So if you are seeing a Q wave in a patient's ECG, what does this indicate? What does this indicate? Now tell me. If you see a Q wave, pathologic Q waves in a patient's ECG, unmute and talk.
Past history of MI. Past history
Yes,
of MI.
excellent. Either he has had a past history within the last 3 to 5 days, or the other important concept I want you all to know, guys, these pathologic Q waves are permanent. So there might be a past MI somewhere long time ago also, right? These are permanent. So he could have had an MI just 3 to 5 days ago, or somewhere else long time ago. Either way, this is not an indication of the current MI. Okay, that's what I want you all to understand. Not the present today's MI. Okay, it takes 3 to 5 days for Q wave formation. Everyone understood this? This is a very basic ECG that I taught you all with two-leads. There is no two-lead ECG that we do. Okay, it's just to make things easy for you all. I hope you all understood this. Even if you all didn't, don't worry. We'll be having a full-blown ECG class, right? I will teach you all the entire ECG section, right? I've written a small mini book also for ECG. I will hopefully one day we'll publish it, right? Okay. Right. Everyone clear after that? Right? All good? Right. Then, so that is what we were looking for. The first thing is the ST elevation. Here, guys, another point about the ST elevation. What do we call a significant ST elevation? Significant ST elevation. Now, guys, if you look at all of our ECGs, if we go take an ECG now, sometimes you and I also might be having some ischemia. Let's say you had a very hard workout today. You might be having some myocardial ischemia, right? Everyone can have a little bit of ST elevations here and there. But there is something called a significant ST elevation that we see in myocardial infarction. What is this? Now we all know. For this, we have to learn about, guys, where the ECG leads are looking at the heart. Right? Now tell me, unmute and quickly tell me, how many limb leads, how many chest leads do we have in a normal ECG? Quickly. No wasting time. Huh? How many limb leads? Tell.
6 limbs, 6 chest.
6 limbs, 6 chest. More specifically, 3. If you take the limb leads, there are 3 real ones and 3 augmented ones. Right? Now look at this, guys. If I draw the heart, right? If I draw the heart, the limb leads are looking at the vertical plane of the heart. What do I mean by that? Right? If this is the center, the limb leads are looking exactly like this. Lead 1, lead 2, lead 3, right? Like this. And then we have the augmented ones, augmented limb leads, right? So we have here on the left side AVL, right side AVR, and here downwards to the foot AVF, right? To the foot, right? This is how the limb leads look at the heart, right? They are looking at the heart exactly in these directions, right? In these directions, in the vertical plane, Then we look at the chest leads. How do these chest leads look at our, draw bigger one, chest leads look at our heart, right? The chest leads, guys, they look at our heart as a cross section, right? They look at our heart as a cross section. So for example, if I draw something like this, right? As a cross section, right? Okay, right? So you will see something like, right? V1, right? What are our 6 limb leads? V1 to V6, V2, right? V3, V4, V5, and finally V6 here, V6. So like if you draw according to the plane, right? It will look something like this. They are looking through this plane, right? Guys, can you all understand what my artwork is not the best, right? They're looking through the horizontal plane. Can you all understand? Did you all understand, right? Okay. Guys, can you all turn your cameras on? At least I can see your faces, if you all are going to faint or what is going on, right? I want to see if you all can, if you all are grasping the concept, right? So this is horizontal plane, right? Yes, sir. Understood, right? Right? Okay. So if they are looking at the horizontal, and here, guys, 3 more leads, right? V7. Here, these are some special leads, V7 to V9. These are posterior leads, right? Posterior leads. Okay. Guys, do you all understand this concept? Everyone understands this concept? Because it's a little bit difficult to move on from here if you all don't understand, right? Give me a thumbs up. Do you all understand how the chest leads are looking at the heart, right? All good? Okay, right. If there is any confusion, just drop a message. If there is any confusion, just drop a message, right? Now, what I want you all to understand by this, right? If you look at 2, 3 AVF, at what direction are they looking at the heart from? Where are they looking at the heart from? Unmute and talk. I just want to make sure you all have understood. Where are they looking at the heart from? 2, 3, and AVF.
Inferior.
Yes, they are looking from the bottom, right? From the bottom down, they are looking up at the heart, right? So these are what we call inferior leads. Excellent, right? Inferior leads, 2, 3 AVF, right? Then if you look at 1 and AVL, where are they looking at the heart from? From the lateral side, the left lateral side, right? So they are left lateral leads, right? Left lateral. Okay. AVR guys, we don't usually care about, right? We don't care about that fellow, right? Let him be. Okay. Then look at these ones. V1 to V6, right? Specifically, guys, if we are talking the heart, the anterior septum, now you all know, if I take the heart, right, here we have the septum of the heart, right? This is how the cardiac muscle is now, right? This V1 to V4, they are looking at this area of the heart, guys, the anterior septal region of the heart, right? V1 to V4, V1 to V4, V1 to V4, anterior septal region of the heart. Then if you take V5 and V6, they are specifically looking at the lateral, left lateral aspect of the heart. Left lateral aspect of the heart. Okay, V5 and V6. Then sometimes we are ordering for special ECGs with this V7, V8 and V9. Where are they looking at? They are looking at the posterior surface of the heart. They are looking at the posterior surface of the heart, right? Now, if I ask you guys, if you imagine the heart like a ball, right? Like a ball, right? If you imagine the heart like this, here we have the V1 to V4, V1 to V4, right? And then here is V5, V6. And here at the back side is V7, V8, V9, right? Now, what do you all think, guys? V7, V8 and V9 is right opposite, right? Right opposite of the V1 to V4. Everyone agrees? Right? They are at the back, right? Opposite to V1 to V4, right? So whatever change you see in the posterior leads, you will see the opposite change here in the anterior leads. Okay. Everyone clear with that? If you see an ST elevation in the posterior leads, in the anterior leads, you will see that same one, but you will see it as a ST depression. Okay. This is what we call reciprocal change. Reciprocal change. Okay, understood. That is simply nothing complex, simply because the posterior leads are in the posterior, directly opposite to the anterior leads, right? Nothing complex. Okay, everyone clear? Right? Right. Now, guys, I have put some ECGs in your note. Take out your note. Let me share the screen here. How do we do this? We'll read some ECGs. This is not the ECG class, but let me. Guys, can you all see my screen? You can see the screen? Yeah? Good? Right. Excellent. You all can see me also? No? It's okay. If you all can't see me, it's still okay. Right? Okay. Right. Let's go through some of these ECGs. Right? So, usually, guys, there are several steps to read ECGs, right? I will teach these all, right, in a separate ECG session. ECG is a separate 4-hour class, right? We'll do that later, right? We don't need to go through all those steps today, right? Here, what I want you all to know, guys. Firstly, what I usually do, these are the simple steps. Always, I start off by looking at 2-3 AVA, right? Whatever ECG paper, now, you all have to know, because now even my final MBBS exam, my emergency viva, they started off giving me an ECG. They gave me an ECG. It was not an ST elevation. It was a VTAC, right? So luckily, right, I was able to get it. But if you all don't know, problem. You all can't progress from there onwards with the remainder of the question, right? Because, right? Don't worry. We'll learn step by step, right? Look at this. Usually what I do is I look at 2, 3 and AVF, right? 2, 3 and AVF, right? Usually, guys, I will teach you all, right? We have to talk about axis deviations. We have to talk about all of those. But today's class, we are talking about acute coronary syndrome. So no need to talk about all of that. Here, where do you all see the ST elevations in this ECG, in this first ECG? Where can you all see the ST elevations? Just tell me, can you all see any ST elevations? No ST. Now, what is the criteria for ST elevation? The J point is elevated from the isoelectric line. The J point is elevated. This J point has come up, right? J point has come up. Can you all see any of the waves where the J point is elevated from the isoelectric line?
V2, V3, and V4?
V2, V3, and V4. Okay. V2, you're correct. V3, yes, the J point is here. V4, yes, again the J point is here. What about V1? Don't you see an elevation of the J point? The J point is somewhere here, right? Somewhere there. So it is slightly elevated from the isoelectric line, right? So here there is a V1 also. What about V5? Look at V5. Here again, slightly elevated, right? From the J point is elevated from the isoelectric line. So here, guys, what can we see? We can see ST elevations from V1 to V5. V1 to V5. We see ST elevations. Now, based on where the heart is, where the leads are looking at the heart, right? We talked about where the leads are looking at the heart. If I say there are ST elevations from V1 to V5, right? How can you describe that ST elevation to me? How will you describe that? We said,
It is anteroseptal.
right. What did we say? V1 to V4, we said they look at the anterior aspect and the septum. We said V1 to V4 is anterior septum. We said V5 and V6 are looking at the lateral side, right? V5 and V6 looking at the lateral side. So if we have ST elevations from V1 to V5, you just combine the two. How do you say the combination of the two? This is a anterolateral MI. Anterolateral MI. Everyone agrees? Everyone agrees, right? Anterolateral MI, right? Okay. We'll come to the second one. Is a little, let's do the third one and then come to the second one. Second one is a little bit complex. I will teach you all. Let's do the third one. Check and tell me, where do you see, what do you see here? What do you see here? What do you all see here? Okay, look at 2, 3 AVF. 2, 3 AVF seems like it's okay, right? 2, 3 AVF, it's okay. Where do you see ST elevations here? Do you see any ST elevations? If so, where?
V1 to V4.
V1 to V4. Okay, let's check. Okay, we see one at V1. Okay, good. Okay. V2. We see at V2 as well. Okay. V3, yes, we see. V4. Yeah, V4 very slightly. This is the isoelectric line somewhere here. This is the J point. Right. Okay. V4 also there is some. V5, good. Y'all didn't mention V5. Good, because there is no ST elevation there. Good, right? Good. I agree. Do we all see anything else specific in this ECG? Now look at our previous wave panel with ST elevations and compare that with this. Anything specific difference that you all are seeing? ST elevations, fine. We can see the ST elevations. Anything else? Anything else? What is this wave, guys? Let me erase this. What is this wave? What is this wave? What are these?
Pathological Q wave.
These are pathological Q waves. Very deep, narrow-based Q waves, right? These are what you call pathological Q waves. What do pathological Q waves indicate? An old infarction. Old infarction. Okay? So this patient, you can see some ST elevations. So where V1 to V4, this is an anterior septal MI, right? Anterior septal MI presenting this time, but this patient should be an already diagnosed ischemic heart disease patient. Okay? Right? Right. Now we'll come to the second one. Little bit tricky, but no problem. You all can take a guess, right? Try to come up with what do you all think? What can you all see? What can you all see? First, look at 2, 3 AVF, right? That's what I advise students to do. First, look at 2, 3 AVF. Anything abnormal there? What do you see?
ST elevation in 2, 3 AVF.
Excellent. We see ST elevations, 2, 3 AVF. All three have ST elevations, right? ST elevations. Then, guys, look at the chest leads. What do you see in the chest leads? What do you see in the chest leads? What do you see in the chest leads?
Depressions.
Where do you see depressions? Where do you see depressions? Good. Where do you see depressions?
V1, V2.
V1, V2. Excellent. V1, V2. Anything else you all see? Look at the other leads. Anything else?
ST elevations on V5 and
ST elevation in V5. Okay, good. And
V6.
And V6. Okay, good. What about V3? Do you all see an ST depression there in V3? No ST depression? There is a slight ST depression, not very significant, but there is a slight ST depression because if you look at the J point, this will be somewhere here. The isoelectric line is somewhere here, right? Slight. It's a slight ST depression, right? Anyway, good. You all identified the main ones. Now, guys, what do we do now? Let's say you get a patient with this ECG. What does this tell you? There is a clear-cut 2-3 AVF, inferior MI, clear-cut inferior MI. And there are some ST changes in the chest leads as well. Specifically, there are some ST depressions in V1, V2, and slightly in V3. What is your next step? What is your next step? And you can see some elevations in some lateral leads also. Okay. What is your next step? What did we say, guys? What did we say? Remember, we talked about reciprocal changes, right? Remember, we talked about reciprocal changes here, right? If you ever see, you do an ECG on a patient. If you ever see ST depressions, specifically in the anterior septal leads, without giving them the diagnosis of, okay, this is a non-ST elevation myocardial infarction, you cannot give them the diagnosis. You must, before giving them that diagnosis, you must do the V7, V8, and V9 to check if there are ST elevations. Why? This can be a reciprocal, what we call a reciprocal ST depression. Okay. So you cannot give them the diagnosis saying this patient has non-ST elevation. No. You have to first do V7, V8, V9. You have to exclude a posterior MI before giving them the diagnosis. Everyone clear up to now? Everyone clear? Right? All good. Give me a thumbs up. Right? I know today's content is a little bit heavy. Right? Good. All good. Right. Okay. Then, guys, we have what you call, where are we now? Talked about this, right? The next change, the next ECG, important ECG change. Yeah. Okay. Ayush, don't worry, right? Now you know how to treat yourself, right? Okay. All right. Okay. Look at this. The next thing, right? Don't worry. If you're in third year, don't try to, you don't need to know A to Z now itself. You have time. You have time. But fifth years, intern students, you all should be familiar with this by now. Okay. Right? Don't worry. Still have time. Still have time. Okay. Don't worry. Right? Guys, I'm telling you, right? Don't worry too much about studying. Okay. Don't worry too much about studying. Right? Specifically in your university life, have a university life itself. Right? Don't be bookworms. Okay. I never advocate for that. I have never been within the top 3 of my batch. Never. Okay. Never. Right? So, right? You have time. Don't worry. Don't worry. Right? Okay. Right? We are not gods, no. We also came through the system. I also have failed many exams, right? I will tell you all later those stories. Otherwise, you always stop coming for my classes. Right? Let's go ahead. Now, right? What do we want to look at next? Here, guys, yesterday we mentioned something called a left bundle branch block. Left bundle branch block. Here, guys, the mechanism of left bundle branch block, I will teach it for you all in ECG. It's quite complex, right? However, what I want you all to know, if you look at lead V1 and look at V6, right? Here, guys, if we look at the QRS complex, as we progress from V1 to V6, there is something called a R-wave progression. What is this R-wave progression, guys? Initially, it's like this. QRS complex is like this. Then as we go up, this becomes taller, right? Taller, sorry. And finally, very tall and like this. This is what we call the R-wave progression, guys. Right? When in a normal ECG, we are talking about normal ECG. QRS complex from V1, V2, V3, V4, V5, and V6 is another one. You can draw another little bit taller, right? This is what we call the R-wave progression, right? All of us, if we do our ECG, this is what it looks like. Now, in a left bundle branch block, what happens is, guys, due to the infarction, right? If there is specifically infarction in the left ventricle, right? There is going to be delays in the transmission of these electrical signals. specifically in the left bundle branches, right? Okay, so what is going to happen is, guys, there is going to be some specific ECG patterns. Now, I'm not going to teach this to you all in depth. It's a little bit complex, so let's not talk about it today. But now just remember the word William, right? William, right? If anyone is interested in knowing this today itself, drop me a message, right? I will discuss it with you over WhatsApp. Okay? No, I have no objection to that, right? But we'll not prolong the class too much because this is not very necessary to know the mechanisms today. Okay? Look at this, guys. William. What do we mean by this William? In lead V1, we tend to get a W-like pattern. A W-like pattern. This is not exactly a W, guys. We will see some ECGs now, right? Not exactly a W, but something like this. Lead V6, of course, we get a clear M-like pattern. Clear M-like pattern. Okay? William, right? So, take your ECGs out. Take your ECG note out and look at the last two. Let me share this again. Can you all see the screen? You can see the screen, right? Yeah, right. Look at this, guys. Look at the last two. Come here, right? If you look at this V1, guys. Look at the V1. This is not exactly a W, guys, but you can appreciate a slight W like that, right? Not exactly a nice W like this. Okay, slight W like that. But look at V6. V6, see, this is a nice M pattern. Even in V5, we can see a nice M, right? Nice M pattern, right? This is a left bundle branch block, right? How this happens, don't worry, I will teach you, okay? I will teach you. If you look at a right bundle branch block, this is the opposite, okay? In V1, we have a M-like pattern, and in V6, we will have the W-like pattern, okay? That's a right bundle branch block. Now, for myocardial ischemia, we are looking for left bundle branch blocks. Just remember William, right? Just remember this. We will talk about how the ECG change happens in another class. I have put another ECG for you all guys. Here also same thing. V6, see, M pattern. And the V1W, not very clear, right? Something like that. Something like that. Okay, right? Don't think about it too much, but this is quite new, guys. This left bundle branch block related to ischemic heart disease is quite a new research finding, right? Not 100% of patients who have a left bundle branch block will have ischemic heart disease. That I want you all to know. But they have found out a correlation. So whenever you see a left bundle branch block in an ECG, you must exclude ischemic heart disease. That is the lesson to be learned here. Okay? Right? Agreed? Right. Then, guys, with that. So now what have we learned up to now? Now you all know, when you all look at the ECG, depending on which leads you see the ST elevations, you all know probably which part of the heart is affected. Agreed? If it is V1 to V4, you all know probably the anterior septal. V5 to V6, you all know probably lateral heart, right? V7, V8, V9, posterior. 2, 3 AVF, inferior, right? Now you all know which part of the heart. Next, we'll also take this one step further. We'll look at probably which artery is affected, which coronary artery is affected. Very easy, right? Nothing complex. So for this, guys, you all need to know a little bit basic anatomy about the coronary artery supply. Nothing complex, right? We'll make it very easy. Look at this. Draw this with me. Okay. We'll draw the heart something like this, right? And here is the aorta coming out, right? And here you all know at the root of the aorta, just at the root of the aorta, right? We have our coronary artery starting, right? Coronary artery starting. Okay. We have two main coronary arteries, right? Two main coronary arteries starting, right? One is the left, one is the right. Okay. This left one, guys, the initial part, we call it the left main coronary artery. LMCA. Can you see? Okay, see. LMCA, left main coronary artery. Okay. This left main coronary artery comes and divides into two, right? Comes and divides into two, right? One of these goes to the side, goes to the lateral aspect, right? And it curves around the heart, right? And goes to the posterior aspect, right? It curves around the heart and goes to the posterior aspect, right? The other one comes straight down in the anterior septal region. The one that comes straight down, guys, we call this the LAD, left anterior descending artery. Left anterior descending artery. The one that goes to the side, right, and curves around and goes to the back, we call it the left circumflex. Circumflex artery. Left circumflex. Okay, left circumflex. Right, that's about the left. Then if you look at the right coronary artery, right, this is the right coronary artery. Right? This right coronary artery, right? The right coronary artery, guys, it comes down a little bit, right? And then it divides into two again, one like this, right? And another branch, again, this branch curves around the heart, right? And comes out, comes behind the heart, something like that, right? Something like this, right? Okay, here, guys, what is this called? This right coronary artery comes and splits into two. The one that goes to the behind, posterior aspect of the heart. This is called the posterior interventricular artery. Posterior interventricular artery, right? The one that goes to the back. Okay. The one that just comes down, this is what we call the marginal branch. Marginal artery of the right coronary artery, right? This entire thing is the right one. Right this way. Right? Okay. Right coronary artery. Understood? Now, very important, guys. This right coronary artery, right? It supplies here before it splits into the posterior interventricular and the marginal. It supplies to some other areas on its way, right? One very important area is the SA node. SA node. SA node is supplied by the right coronary artery. Okay, SA node is supplied by the right coronary. Okay, right, understood. Now look at the other places, other supplies. Let's look at left. Okay, let's talk about first the left anterior descending. Where does the left anterior descending, based on this diagram, where do you think it supplies to? Left anterior descending, guys, it supplies to the anterior septal portion of the heart. The anterior septal portion of the heart, blood supply. Okay. Then if we look at the left circumflex, where does it supply to? The left lateral surface of the heart. Left lateral surface of the heart. Right? Okay. The marginal branch, guys. Marginal branch, where does it supply to? Based on this image, it supplies to the right lateral surface of the heart. Okay, right lateral surface of the heart. If you look at the posterior interventricular artery, guys, posterior interventricular artery supplies to a large portion. Specifically, just as the name suggests, entire posterior aspect of the heart is supplied by the posterior interventricular artery, as well as, you all can see this dotted line, this guy comes all the way down, guys. He comes all the way down at the posterior side. That's why I have drawn it in dotted line. Huh? So the posterior interventricular artery also supplies to the inferior surface of the heart. Inferior surface of the heart. Now, based on this picture, tell me, if I'm telling you all there is a large atheromatous plaque in the right coronary artery, here, large atheromatous plaque, what can happen? Where can you see ST elevation? Where can you see ST elevation? You can see ST elevations. One might be in the posterior legs. Remember V7, V8, V9? Posterior legs can have ST elevations. Another one, inferior surface of the heart. 2, 3 AVs can also have changes, ST changes. And what else can the patient have? Patient can develop arrhythmias. Why? SA node is also supplied by right coronary artery. Okay, everyone agrees? Everyone agrees, right? Now I'm telling you, now based on this diagram and the previous diagrams that we have drawn, I am telling you, there is a myocardial infarction. There is an ST elevation somewhere in the leads V2 and V3. Tell me which artery is most likely the problem. Which coronary artery is most likely the problem? If you are saying ST, LAD, correct, right? Excellent. Left anterior descending artery is the most likely affected artery. If I'm telling you there is a ST elevations in V5, V6, what is the most likely artery? Most likely left circumflex artery, right? Good, excellent. So you all have understood. This is it, guys. This is it you all need for your MBBS. Okay, right? So you look at the ECG, you check where the ST elevations are. Based on that, in your mind, the artery should come to your head, right? The artery must come to your head. That's it, right? So now majority of the students, they try to memorize this. Don't memorize, because if they show you an ECG in the exam specifically, let's forget about exams. For patients in real life, when you see an ST elevation, right? Someone might say this is most likely a left-sided MI, but you can say what? Most likely left circumflex artery is involved. Let's do a angiogram. Let's look at if you do the angiogram, where should you send the angiocath to? To the left circumflex artery to see if there is a obstruction. Okay, understood, right? Okay, right. So I hope you all understood this. So now you all know how to find where the lesion is, where the problem is in the coronary system. Okay, everyone clear with this? Give me a thumbs up. A lot of energy. Yeah. Okay, excellent. Okay, lot of fuel gone today. I need to eat like a big. engine students, any fans of fried rice? Chow fan? Yeah. Okay. So that used to be my go-to meal, right? Study all throughout the day. We have like a friend group, so we would do discussions all throughout the day. Especially when it's like 2-3 days for the exam. Late night we will go. We have a small place called Ibu, so we will go order six fried rice, right? Bring and eat all throughout the night. Then take another coffee all throughout the day again. Last 2-3 days for the exam. That's how we used to. Fun days, right? Okay, right. Okay, so where did we? Right now, so we have talked about the ST elevations. Now a little bit more things to talk about, guys, before we end today's class. Now, what is the significant? Now we said all of us can have tiny ST elevations, but what do we mean by a significant ST elevation? Now, you all know, guys, if we look at the ECG paper, there are large squares, right? And those large squares are further broken down into 25 smaller 1, 2, 3, 4, 5, and 1, 2, 3, 4, 5. 25 small squares, right? This is how your ECG paper is now, right? And each of these squares, if you look at the height, it's 1 millimeter. The height is 1 millimeter. Okay, right? What is the significant ST elevation, guys? Now, what did we talk about ST elevation? J point elevated above the baseline. We say it is a significant ST elevation if we are considering leads V2 and V3, right? Leads V2 and V3. If the ST elevation is more than 2.5 millimeters, that means this part, more than 2.5 millimeters, right? In males less than 40 years of age. That means in you and I, right? In the males here and I, right? We are less than 40, right? So if the ST elevation is more than 2.5, that is significant, right? Then in a male patient who is more than 40 years of age, an ST elevation of more than 2.0 millimeters is significant. It's significant, right? And in females, any age. For females, we don't put an age cutoff. For females, any age, if it is more than 1.5 millimeter, we take this as a significant ST elevation. This is in leads V2 to V3, right? In leads V2 to V3, right? Then, if we look at in the leads V4 to V6, right? Any ST elevation in anyone, if it is more than 1 millimeter, greater than or equals to 1 millimeter, we take it as significant. Here there is no sex difference, there is no age difference. V4 to V6, any ST elevation more than 1 millimeter is significant. Right? Same in the limb bleeds, guys. What do we say about the limb bleeds? Limb bleeds, we have 2-3 AVF or the augmented leads, right? AVL, AVF, right? AVR we don't usually consider. So limb bleeds also same. So you can put limb bleeds or V4 to V6, both. More than this 1 millimeter is significant. Okay. And the last one, V7 to V9. In V7 to V9, guys, any ST elevation, sex doesn't matter, age doesn't matter, any ST elevation more than 0.5 millimeters is significant. So very easy to remember, 0.5, 1, 1.5, 2, 2.5. Okay. Right? Okay. Understood? So this is what we call a significant ST elevation, right? Then, right, look at this, guys. Now, everyone clear about this, right? Now, when coming to the management, guys, look at this. Now we'll come more towards the management side of things, right? What are our management options? What are we looking for in the ECG? We said we are looking for ST elevation myocardial infarction. We are looking for a new onset left bundle branch block. We can look for non-ST elevation myocardial infarction, or again a non-ST elevation presenting as unstable angina. These are our 4 ECG findings, though, right? These are basically our 3 ECG findings, right? Here, guys, if we see an ST elevation MI or a left bundle branch block, what does that tell you? What does that tell you? If you look at the heart, full thickness of myocardium is affected. Full thickness of myocardium is affected. Okay. What does that tell you about the coronary vessel? Fully obstructed by a large thrombus, right? So if that is the case, guys, what is our management there? Our primary management is to break this thrombus. Our primary management here is thrombolysis. We are trying to break the clot. Okay. If it is a non-ST elevation MI, what did we say? This is usually subendocardial, right? Subendocardial. And what did we say about the coronary vessel? It's partially obstructed, right? So what do we want to do, guys? We want to prevent this one becoming a full obstruction, right? We want to prevent this from becoming a full obstruction. We want to prevent further thrombus formation, right? Therefore, what is our primary management here for non-ST elevation myocardial infarctions and unstable angina? Here, we want to anticoagulate the patient. Everyone agree? Anticoagulate the patient. Okay. Everyone agrees, right? These are our mainstays in management. However, if we consider all 4 of these guys, what is our best management? Best management is what we call primary PCI, percutaneous coronary intervention, right? What do we do? Nothing, guys, just a big word, right? Just a big word to scare you all. There is a thrombus like this, right? What are we going to do? We are going to insert a cath, right? A fine wire. This wire has a balloon that can expand. It has a balloon that can expand, right? So what will happen? We go in and we expand this balloon. So what will happen when we expand the balloon, right? This thrombus will get sort of like crushed, right? And we are opening this vessel nicely using this balloon. Now, sometimes, guys, this balloon also has a stent, a metallic stent, which we can leave there, right? Which we can leave like this. I will draw a stent like this, which we can leave, a metallic stent, right? This is metallic stent. And we can retract that balloon back outside, right? We expand, this had a stent, right? A metallic stent, and we retract the balloon outside and we leave that metallic stent there. This is our percutaneous coronary intervention, right? Percutaneous coronary intervention. Okay, this is the best management. So what do I mean by this is the best management? If we get a patient coming with acute coronary syndrome, what are we going to do? We are going to attempt this. We are going to attempt PCI because this is the best for the patient, right? However, there is a problem with availability. PCI is not available everywhere. Specifically in our countries, in the peripheries, no PCI, right? Here, right? This is very important. How can we decide if we are going to do PCI or not, right? Here, guys, for the PCI to be done, the first thing is, right, what we call the door to balloon time, right? Door to balloon. Okay. What do we mean by this? Door to balloon. Door means what? The time the patient comes to the hospital. The time the patient arrived at the door of the hospital. That is door. Balloon means what? You're doing the PCI. You're putting the balloon. So this door to balloon time, right? Door to balloon time should be ideally less than 90 minutes. If we can do a PCI, right, within less than 90 minutes, we must go for PCI. That is our best option, right? We must do a PCI. Then let's say now, okay, you got a patient coming in, you diagnosed acute coronary syndrome, ECG, everything very clear cut, right? You started the stat doses, everything. Now you're quickly calling your hospital. You're in a peripheral hospital. You're calling the cath lab, right? hello, good morning. I'm Dr. This, right? And you're calling the cath lab. You're in a peripheral hospital. What are they going to say? Sorry, sir, wrong number. This is not the cath lab. We don't have a cath lab in this hospital. Okay. What are you going to do? What are you going to do? Right? Call the nearest hospital. Call the nearest hospital. Right? This is what actually happens. You have to call the nearest hospital and see if there is a cath lab close by. Right? Specifically, you can call something like a base hospital. Right? You call a base hospital, right? Or group A base, you all know, right? You can call them. You ask, is PCI available? They might say yes. They might say yes. Now it is your judgment call. What is the judgment call, guys? If you can get the patient to that hospital within a maximum of 120 minutes, 2 hours, maximum 120 minutes, then you send the patient. You send the patient, right? You send the patient to that hospital. If you cannot, if you know this hospital is too far away, or there is I don't know, there's a huge traffic. You know you can't reach that PCI within 120 minutes. You start either thrombolysis or anticoagulation, depending on the patient's ECG. You must start these, right? If the patient showed ST elevation, start thrombolysis. If the patient showed non-ST, start anticoagulation. Okay. Everyone clear? Everyone clear? This is your management. This is your management, right? So what are the things? Door to balloon time less than 90 minutes is best, right? But you have a maximum window of 120 minutes. If you can get the patient to PCI, get him to PCI. If not, if 120 minutes exceeding, start the patient on thrombolysis or anticoagulation, depending on the ECG. Agreed? Thumbs up, right? Okay. Right. Now, then let's move on. Now, okay. Let's say, now you are working at a base hospital. Huh? You ranked in ERPM and they have put you to, you're working at NHSL, right? National Hospital. Huh? Okay. Right. Right. Don't expect that. Right. But right. We'll talk about ERPM later. Right. Okay. So now you have PCI available. You have PCI available. Catheter, the cath lab is available. Right. PCI is available within 90. Let's say it won't take 5 minutes for you to take the patient to the cath lab. Okay. Now you will not do this thrombolysis. Right. You will not do this. Okay. Don't do thrombolysis or anticoagulation. Send the patient to PCI. After the patient comes back, we can see what to do. Here, guys, now in case this wasn't done, what did we say? We'll go one by one. We'll say this is scenario 1. This is scenario 2. The patient is having an ST elevation or a left bundle branch block. What is our management option? Thrombolysis. What are our options here? What are our drug options? Have you all heard about thrombolytic agents? If so, what? Commonly, guys, we use something called streptokinase. Streptokinase, right? Streptokinase. This is our thrombolytic agent. Okay, streptokinase. So what are the indications that the patient should have for us to put the patient on streptokinase? What are the indications? Tell me one indication based on everything that we have learned up to now. One main indication. One obvious indication. Tuck. Little more to go, guys. Little more to go. Come on. Today is a little bit heavy, I know. Right? What is one obvious indication, guys? PCI not available. PCI not available on time. So we have to go for thrombolysis. That's the first one. The next thing, right? The next thing is, guys, the onset of the pain. The first one, write down. Second one, onset of chest pain. Onset of chest pain should be no more than 12 hours duration. 12 hours duration. The chest pain. Now, previously, what did we talk about? The 90 minutes and the 120 minutes? That is door to balloon. The time the patient arrives at the hospital. Right? Here, onset of the chest pain, 12 hours. Okay? Maximum 12 hours for you to start streptokinase. Okay? Right. Then the next thing, ECG evidence. There must be, obviously, guys, there must be ECG evidence of acute coronary syndrome. ECG evidence of acute coronary syndrome must be there. Must be there. Right? Okay. And the last one is there is no contraindication. No contraindication. What are these contraindications to streptokinase or for thrombolysis? What are the contraindications? Write these down. Now, what do you think? Okay, what does the thrombolysis do? It goes and breaks down the thrombus, right? Breaks down the thrombus. What can be a contraindication for breaking thrombuses in our body? What do you all think? Just basically, just think about it, right? what can be a contraindication against breaking thrombuses in your body? What do you think? Any idea? Think. Guys, you all have to be active, huh? Otherwise it's difficult, right? I need some glucose now, huh? Right? And the heat is also not helping today, right?
Any active bleeding?
Excellent. Who was that? Manari, right? Right. Good. Any active bleeding, any evidence of active bleeding. So, for example, guys, specifically, any recent is hemorrhagic stroke, right? Any recent hemorrhagic stroke, any active internal bleeding within the last 2 to 3 weeks, right? So, for example, if the patient has had melena, right, very dark stools, dark tarry stools, or if he has had hematomesis, right, these are internal bleeds, right? So, something like portal hypertension, right, in alcoholic cirrhosis, right? If they have had those kind of symptoms, cannot give thrombolysis, right? Why? Because there is probably a clot that has formed that is protecting that patient from further bleeds. So, if you give thrombolysis, that will go and break that clot, right? Then, past ischemic strokes also, right, within the last 6 months. Why ischemic strokes, guys? Even ischemic strokes, right? If there are clots in different vessels of the cerebral vessels, we talk about the neurology, right? We talk about this later. Those, once you break those clots, guys, let's say there is a vessel like this. Vessels, you all know, as they go further and further, they become thinner and thinner. They become smaller and smaller. Let's say there was a clot somewhere here, right? Clot somewhere here giving rise to some ischemia, right? But after a while, the patient was fine. And now you give thrombolysis. You break this clot from here, right? This clot starts traveling here, and completely obstructing this. That will cause what? It's ischemia to this entire other new place. Okay. So this is why even in ischemic strokes, within the last 6 months, usually, we don't give them thrombolysis. Okay. These are contraindications, right? Then another one, aortic dissection. If the patient was a diagnosed patient with aortic dissection. Also, there might be thrombuses that have nicely healed the area. You don't want to break that thrombus and dissect it again, right? Then apart from that, guys, any arterial punctures within the last, so if they have done ABGs, right, especially within the last 7 days, you cannot, right? Arterial puncture, because there will be arterial bleeding. Very difficult to stop, right? Okay, so these are some contraindications for thrombolysis. Okay, right? Understood? Right. The next question, guys, you all need to know how to give streptokine. How do we administer streptokine? Streptokine, guys, these are coming in small vials. I think I have put an image. I will show you all. Yeah, you all can see the screen, right? This small vial, right? So this is, this is 1.5 million, right? So this is 1.5 million international units. This is the one we use, right? What we do is we take 1.5 million units. We take this entire vial. We dissolve it with 100 ml of normal saline, and we give it as an infusion, usually 1 to 2 hours infusion. Okay, this is how we give streptokinase. Usually to a peripheral vein, not to central veins. We don't give streptokinase to central veins. Always to peripheral veins. Okay, always to peripheral veins. 1.5 million units dissolved in 100 ml of normal saline, given over 1 to 2 hours. 1 to 2 hours. Okay, right. Then, now, the next question is, streptokinase now is a little bit old, guys. Now we have some new options. What are these new options? Have we all heard something called RTPA? What is this? Recombinant tissue plasminogen activator, right? These are the ones now we use more than streptokinase, right? RTPA, guys, why we like this RTPA? One thing, now what are these doing? They break the thrombi. This RTPA is very fibrin specific, guys. It goes and attacks only the fibrin molecules and therefore breaking the fibrin mesh and breaking the thrombus, right? So that is one reason why we like it. It's very specific to fibrin. The other reason is streptokinase. How do we take streptokinase? How do we make streptokinase? Streptokinase is, it's a very lengthy process. There is PCR and everything involved. But basically, these are produced by streptococcal species, right? We culture these organisms. We can grow them with ease, right? And then we can extract the specific genes that produce the protein and PCR, and then get the substance like that. So whatever, streptokinase is taken from biological organisms. So there is always a chance of them, those proteins, acting as antigens and causing anaphylaxis. Anaphylaxis, right? Streptokinase is highly known for its anaphylactic side effects, right? Anaphylactic side effects. That is why we again prefer RTPA, recombinant histoplasminogen activators, more than streptokinase, right? Okay, so what are the examples, guys? You all might have heard all this place stuff, 10-active altiplase, retiflase, right? These are RTPAs, huh? RTPAs, right? Okay, right? Then, so that is about thrombolysis. Anticoagulation. How are we going to anticoagulate a patient? How are we going to anticoagulate? How will you anticoagulate the patient? If the patient is coming with a non-ST elevation, right? It's either myocardial infarction or unstable angina. What is our drug of choice here? What is our drug of choice here? Our drug of choice here is, guys, heparin. Specifically, low molecular weight heparin. Low molecular weight heparin. Okay. The example we are commonly familiar with is enoxaparin. Okay, enoxaparin. Right? Enoxaparin. This is usually given subcutaneously, guys, around the umbilicus. Right? Around the umbilicus. Right? Around the umbilicus. So you all remember initially we talked about the history taking. We talked about what has been done up to now. What is another question you can ask from the patient? Have you been given, after coming to the hospital, were you given any injections around your umbilicus? That's another question you can ask, right? And this one, thrombolysis. What is this? An infusion to the arm over 1 to 2 hours. So you can ask the patient, were you given any infusion to your arm for about 1 hour, for about 2 hours? You can just ask to get an idea, because the patient is not going to tell you in the exam, I am a ST elevation myocardial infarction. No, all he's going to tell you is chest pain. Okay, right? So these are things you can ask. So low molecular weight heparin, enoxaparin, subcutaneously, subcut, usually given around the umbilicus, right? Injections around the umbilicus. Now, RTPA, guys. How do we give RTPA? This is another question they like to ask. How will you give RTPA? Now you all know how to give streptokinase. How do we give streptokinase? 1.5 million units, dissolved in 100 ml of normal saline, right? Given as an infusion over 1 to 2 hours. Okay, agreed, right? How do we give RTPA? How do we give RTPA? Basically, our retiflase, tenecteplase, altiplase, how do we give these medications? Here, guys, now what did we say? These ones are highly fibrin specific, right? Highly fibrin specific. So they can break clots very, very efficiently, right? They can break clots. Clot breaking ability is very efficient, very efficient. What is our fear? What is our fear? This might go and break some clots where we don't want them to break, right? Some important places. This is why there are contraindications. Because there are some clots that our body actually needs in some areas, that some minor bleeding areas where the clots are needed, we need those clots. So always, guys, right? Always, before giving RTPA, right? Before giving RTPA, we want to prevent any other places clot breaking and clot formations also, right? Clot breaking and clot formations also, right? Because of this, how are we going to give? How are we going to give this? Any ideas? Any ideas? How can we give this RTPA to the patient? Here, guys, more simply, if I tell you, right? If I tell you, I want to, now I'm giving thrombolysis to the patient. Right? What can happen if I give thrombolysis to the patient, like I drew here, like we talked about here? Let's say a coronary artery itself. Let's talk about a coronary artery itself. Let's say there was a thrombus here, and now you gave RTPA. This thrombus broke off from here, moved down and obstructed another area. When there was one infarction, right? And yesterday also we discussed about this. About 3 to 5 days later, the patient is complaining of the same thing. What is this? Same manifestations coming again. What is this? We talked about reinfarction. Now, when we are giving RTPA, there is a very high chance of reinfarction. because they break clots very easily, right? Okay, so to prevent that, guys, when we are giving RTPA, how do we give RTPA? First, we give them anticoagulation, right? First, we anticoagulate the patient. How do we anticoagulate the patient? We give them IV enoxaparin, right? Okay, we give them IV enoxaparin, right? IV enoxaparin, anticoagulate the patient, right? Usually 30 milligrams. 30 milligrams is enough, right? And then we give them the Retiplase, Teniplase or Altiplase, whichever is available in your hospital. You give the RTPA, right? And then RTPA is given according to the age, guys, right? There are some cutoffs. If the patient is less than 65 years, how do we give it? If he's more than 65, how do we give it? No need to know for MBBS. But what we should know, we never exceed 100 milligrams. Just know that. Never exceed 100 milligrams RTPA. Okay? Never exceed. So we anticoagulate the patient, first put him on IV enoxaparin, then give RTPA based on the age. Based on the age, we give RTPA and the weight, age and the weight. You all can write age plus weight. Okay. Based on that, we give the RTPA dose. And then after giving the RTPA dose, again, we have to put the patient on anticoagulation, right? For about 3 to 5 days. 3 to 5 days. Okay. Anticoagulate the patient again for about 3 to 5 days, specifically because we are afraid of this reinfarction. Okay. Everyone clear? Everyone clear about this? Okay. Right. Then, now, let's say you thrombolize the patient. Let's say you had a patient with ST elevation. You thrombolize the patient. Now, how are you going to find out if your thrombolysis was successful or not? This is the next part. You had a ST elevation. How do you know if the thrombolysis was successful or not? Right? How will we know? One thing is, guys, obviously, what should happen? Pain should be gone, right? The patient should have pain relief, right? Relief of the pain. That is the first point. Patient should appear clinically well, and there should be pain relief, right? Second point is, guys, this ST elevation should be reduced by at least 50%, within the first 90 minutes, of giving streptokinase or the RTP, right? Okay. At least a 50% reduction, in the ST elevation. Okay. So what does this tell you? Within 90 minutes, you must again do an ECG, right? You must again do an ECG to check, right? Then, guys, there is also what we call a reperfusion arrhythmia. Now, look at this, guys. If there was an infarction here, right? Okay. If there is an infarction here, guys, usually the surrounding areas will also be a little bit ischemic, right? Now, what do? We thrombolize the patient. What happens when we thrombolize the patient? These areas receive blood. When these areas that were ischemic, when they suddenly start receiving blood, what happens, guys? They start getting a little bit hyperactive. Like us, no. If we are suddenly given, if we are losing energy, now if I eat a good fried rice, right, I also will get some energy, right? So same principle. If the ischemic area is provided blood, this guy will start getting a little bit hyperactive. When this guy starts getting hyperactive, guys, there can be some ectopic focuses firing electrical signals from these areas, right? These are what we call this. So this will lead to arrhythmias. Now, these arrhythmias, are they bad? No, because these arrhythmias are an indication that our thrombolysis therapy is working, right? These arrhythmias are an indication that thrombolysis is working. So that means what? Specifically, if these arrhythmias are seen, these are what we call, guys, there is something called accelerated idioventricular rhythm, right? These are, no need to know, right? Just know, guys, this accelerated idioventricular rhythm, right? I will teach you all later in ECG. Basically, the rate is lower, around 50 or 40 beats per minute. There are some wide QRS complexes, right? We'll talk about those later. But for now, no. There can be what we call we call these reperfusion arrhythmias. Reperfusion arrhythmias, right? If they ask, what is a reperfusion arrhythmia? If you know, that's enough. These are harmless arrhythmias that are seen in a patient who has undergone thrombolysis. And this is an indication of successful thrombolysis. If you know that much, more than enough. Okay? All good? Thumbs up? Right. Then guys, the last thing for today, what is your long-term management plan? How do you, basically what I'm asking is, how are we going to discharge the patient home? This is the last concept for today, right? How are we going to discharge the patient? First thing is, guys, look for and manage any complications. So for example, if the patient had an MR due to this ischemic heart disease, due to the acute coronary syndrome, manage that before sending him home. You have to manage the heart failures. Any complication, manage, right? That's the first one. If they have pericarditis, manage that, right? Then guys, second is our maintenance medication, maintenance doses. What are these maintenance doses, guys? Look at this. The same stuff. Aspirin. Remember our stat dose? Aspirin was 300 mg. Here we give 75 mg. Usually Nocta, right? 1 tablet at night, right? Aspirin 75 mg Nocta. Clopid 75 mg Nocta, right? Then we can have statins, something like Atorvastatin 40 mg Nocta, right? Atorvastatin 40 mg Nocta. Okay. Then apart from that, we can put a nitrate. Something like GTN, or we can put isosorbide mononitrate or isosorbide dinitrate, right? Whatever, right? Depends from patient to patient, right? And then we put the patient on a cardioselective beta blocker, right? Cardioselective. What are our cardioselective beta blockers? Give me some examples. What? Cardioselective beta blockers. Come on. Huh? Almost done with today's class. I know it took a little bit longer. Huh? Come on. Cardioselective beta blockers. Yesterday's class. Huh? Give me one example.
Metoprolol,
Good. One more.
bisoprolol,
Good. One more.
carvedilol,
Excellent. Okay. Right. A to M, right? You all remember, no? Carvedilol, bisoprolol, metoprolol, all of these things, right? Yeah, cardioselective beta blocker, and we also put them on an AC, angiotensin converting enzyme inhibitor. You all have heard all the prils, enalapril, captopril, right? So these ones, guys, usually 2.5 milligram dose is enough, right? Again, Nocta, right? So yeah, these are our basic medications that we put the patient on, all right? Here, guys, right? Specifically, if you look at, right, aspirin, clopidogrel, right, the beta blockers, ACEIs, and even Atova, right? These ones usually have what we call a mortality benefit. They have a mortality benefit. Okay, mortality benefits. Okay, so these are coming in your MCQs, right? Now, across the next few days, I hope you all have joined the quizzes group, right? There's a quizzes group in our community. Just join that. We are going to post some ischemic heart disease related questions, right? We'll put some questions there. Try to answer those, right? Okay. This is very common in MCQs. Right. Then, guys, again, now we are talking about the long-term management or the discharge plan, right? So we put the patient, we'll manage any complications, put the patient on maintenance doses. Remember, during the acute management, if it was a diabetic patient, what did we do? Diabetic patient who was on oral medication, what did we do? Do you all remember?
give insulin,
Yes, we converted him to insulin. Now, when discharging him home, what should we do? Convert him back to his usual oral regimen, right? You check the compliance. You can check if his glucose is well controlled. If not, you can add some more medications. But however, you don't send the patient on insulin, okay? Convert him back to so that's the third thing. If it was a diabetic patient, convert him back to his usual oral anti-diabetic medications, right? Then finally, you also have to advise the patient on lifestyle modifications, right? To do some exercise, right? And to come for regular follow-ups. Here, guys. Now this patient just had an MI. How are you going to advise me regarding the initial first week? Can I just go home and start my usual work, right? If I had a very large MI? How are you going to advise me? What do you think? Come on, now I'm the patient. Huh? Someone just unmute and tell me, let's just talk last 5 minutes. Huh? I'm the patient. I just had an MI. What are you going to tell me? Go home and wash clothes. Huh? Now, the wife was busy these 2 weeks dealing with your problem. Now you go and cook some food. Huh? That's what you're going to say. What do you think? What do you think? Guys, look at this. Okay. First day, day 1, after going home, day 1 to 2 actually. Complete bed rest. Day 1 to 2, complete bed rest. Okay. No work, nothing, complete bed rest. Day 3 to day 4, you can tell them, okay, you can walk around you can stand a little from the bed and walk around the bed, walk around your room. That's fine. Right? Day 5 to 6, you can mobilize a little more, walk around your house. Right? Walk around your house. But again, no running, no jumping, no udalugano, anything at home. Right? Okay. Indian students, I was just saying no farming. Okay. Okay. Right. Day 5 to 6. And after day 7, usually they can mobilize and do some activities, but again, not strenuous activity. Up to about 1 month, no strenuous activities, right? Usual daily activities are okay. Here, guys, you have to tell the patient to come for a follow-up within the first 1 to 2 weeks. First 1 to 2 weeks, come for a follow-up. You have to do an ECG again, right? You have to look, what are you looking for? Pathologic Q waves. You're going to look for reinfarctions, right? You're going to look for these things. So come for a follow-up within the first 1 to 2 weeks. Then after that, after the first month, come for another follow-up like that. Little by little, you can taper. After 3 months, come for another follow-up like that. However, guys, usually more than 95% of the patients will be on aspirin lifelong, right? After an acute MI. Okay. Majority, more than 90% of the patients will put them on lifelong aspirin. Okay. Right. Everything clear. That is it for today's class. Okay. So that is it for your ischemic heart disease. Everything that you need to know for your MBBS, right? There is nothing more than this. Nothing more than this, right? So I hope you all understood the concepts. Don't try to memorize, right? Don't try to memorize. You all see how simple it is when you understand. Okay. Later, obviously, when you all are like 1, 2, 3 days away from the exam, there are things you need to memorize, right? But now you all are 4th years, 5th years here, right? Try to understand concepts. Okay. Right? Okay, guys, then that's about it for this session, right? Hope to see you all again soon. We are going to put up a lesson plan. We are going to do multiple topics from we are thinking of doing multiple topics from different modules. We're not going to do one module at a time. For the time being, we are going to do ischemic heart disease from cardiology, right? Then strokes from neurology, right? Like that, from different modules, different important topics. These are the most important things. Ischemic heart disease, acute coronary syndrome, 90% of your Viva exams, you all will get ischemic heart disease, right? 90%. So we'll select the most important topics, and we are going to do these topics for you all, right? I will put out a lesson plan. If you all have any suggestions, just drop me a message. No problem, right? We are open to suggestions, right? Yesterday, a student had a message asking if I can also teach surgery and genomes, right? Right at the moment, not really, right? We'll see sometime later. For now, we'll stick to medicine, right? Open to suggestions, whenever you all want, just message me. And if you all have any question, guys, medicine related, any question, doesn't have to be cardiology, anything, medicine related, any question, drop me a message, right? Always willing to help, right? Okay, guys, then that's about it. Thank you for joining, right? Most welcome, right? Okay, see you guys. Okay, you're welcome. Okay, right?